right, a warm welcome to you. We're starting in 34 seconds, kicking off the formal opening ceremony for Teach to Reach. 30 seconds away now. You can count down with us, and you should be by now in the plenary inside. Hop in. I'm going to show you that in a second. Here, this is where you should be, or actually here is where you should be, and you'll see the opening ceremony happens on the stage, so you should go to the live stage and be able to see this live stream. If you're stuck on YouTube or if you're in our Zoom studio, that is fine as well. All right, let's go. Warm welcome to this opening ceremony, really celebrating the movement for Immunization Agenda 2030. Let's just need to complete the slide. You know that on the 28th of April, 2021, we asked you this question: what is the future of immunization? And there is a saying now, I think pretty much every culture, every country says this is a saying of their country or their culture, and that is, if you want to walk far, walk together. And so something happened on the 7th of March 2022 when over 6,000 health professionals from 110 countries committed to contribute to a global movement for Immunization Agenda 2030. We launched a call calling TGLF's platform members, immunization professionals, who are today 45,641 in number, to connect not only with us, but to connect with each other. And this is a global movement which we need everyone, and we're only one of the many organizations making a contribution. This was following the unanimous adoption by countries at the World Health Assembly of Immunization Agenda, supported by partner organizations. This was called for by the Director General of WHO, who called for a broad social movement for immunization that will ensure immunization remains high on the global and regional health agendas. And our starting point was that as health professionals, your commitment can make a difference for children and their families in your country and in every country. And we said, here is why you matter. We know that people working at different levels of the health system, including the most local levels, are the key to leading change. And so we launched what we call at the Geneva Learning Foundation, the first full learning cycle, challenging you to stay the course during 16 weeks of continuous, intensive, shared learning and collaboration, going from knowledge acquisition, which is necessary to get the best available global knowledge from the best available experts. But that is no longer sufficient to take it forward, to go to action planning, to implementation, to improvement. And we asked you, do you face any of these challenges? Children who are unvaccinated, epidemic outbreaks, lack of confidence in vaccines, marginalized communities, gender barriers, and 8,377 of you not only said, yes, we face these challenges, but we're ready to make a commitment to the movement. And this is where I turn to Charlotte to read the pledge that each and every member of the movement has made, each and every scholar, as we call participants in our programs, has made.
I am committed to work for a world where everyone, everywhere, fully benefits from vaccines to improve health and well-being. As a scholar, I hereby solemnly pledge to work with others to transform projects led by scholars into action and results that will improve immunization outcome. To share my success as well as my challenges by reporting on a regular basis on my progress towards implementation. Support fellow scholars in doing the same while upholding the highest standard of integrity and behavior. I make this pledge for the health of children and families in my country and everywhere. Thank you.
So after 16 weeks, today is the day when we complete the first full learning cycle. Let's go take a look at some of the comments inside the Hop-In conference platform. So I'm just going to show a few. Here we have Pam Yakubu from Plateau State, Nigeria, Adebake Oguntona. Subarna shares his applause. Izeani says, I'm very excited to be here. A lot to learn today. It's coming from Anambra State, Nigeria. Joyce Murithi says, this is awesome to see the movement get to this point. And Abebe Sorsase has asked if the session has started already. So Abebe, please check the schedule. That should hopefully work out work out better for you. Now, here is the recap, actually. Just for those of you who have not yet joined the movement for IA 2030, there are many people who are at Teach to Reach for the very first time. This is what it looked like from the 7th of March until the 17th of June, until today. And these are some of the numbers, some of the outputs, let's say, rather than tangible results. It started with the ideas engine. And this is where a number of amazing things happened, or started to happen. The Ideas Engine provides a platform for practitioners to share ideas and practices. And in 2 weeks, you shared almost 1,000 ideas and practices in the Ideas Engine, with 62 countries contributing. And because this is about Immunization Agenda 2030, you can see the breakdown here by strategic priorities. We then moved on to situation analysis, analyzing, finding the root cause of your chosen IA 2030 priority challenge. And again, working together, participants from all over the world developed 664 situation analyses, 48 Anglophone countries, 24 Francophone countries, and you focused on COVID-19 vaccination for 47%, almost half of you, reaching zero-dose children, more than 40%, adults and children missing their vaccinations, 40%, disruptions to RI, to routine immunization, 29%, introduction of new vaccines, 17%. Now, when we asked you what's situation analysis about, it's about finding a root cause that is different from what you initially thought or identified as the cause of your IA 2030 challenge. And for the Anglophones, almost half of you found a root cause difference, leading into the Action Plan Hackathon from the 9th to the 20th of May, where in 2 weeks you developed more than 1,000 action plans, focused each of them on the strategic priority of IA 2030 and what we call key focus areas. And again, at the top of the list, we're reaching zero-dose children, COVID-19 vaccination, and other areas. You did say that it was going to take longer than 2 weeks or 4 weeks in order to implement those action plans. And that's where we kicked off the launchpad of the Impact Accelerator. We asked you a very simple question. Fine, you developed an action plan. Now, are you ready to take action? And this time, 4,149 of you said that, yes, you're ready to do exactly that. Focusing on 4 pillars: the pledge, which you heard, the measurement, the sharing, and mobilizing. And here we saw very quickly remarkably early successes and lessons learned as movement participants, movement members challenged each other to do better, to go further. Experience sharing sessions led by Charlotte Mbou and François Gass, helping members share experience and sharing their own experiences. And then the IA 2030 twins, not successful for everyone, but when it works, potentially gives you a friend, a buddy, a partner for Immunization Agenda 2030. A lot of mutual aid between members, a measure using an evidence-based value creation network of tracking what value is actually being created through all of this hubbub, all of this activity in digital spaces. And then when we asked you every week, what did the movement change for you? We got thousands of answers, but we want to hear your answers firsthand now. And so I'm going to turn to Charlotte. There are folks in our Zoom studio who have given this some thought, and we gave you a long series of questions. We've boiled them down to 3 for the purpose of this plenary. When and why did you join the movement? That's question 1. The why is the important part. What is your priority challenge, and how has your participation in the movement actually changed you? Charlotte, over to you.
Thank you very much, Reda. I need to be co-host so that I can invite others to unmute themselves, but I'm inviting you right now to raise your hand if you want to tell us why. So Reda, if you can activate, I'm inviting Ahmed Neama, if you're okay. Ahmed, if you're able to unmute yourself. Okay, over to you, and please do start by introducing yourself.
Hello, Charlotte, Rida, and hello, my dear colleagues. I am Ahmed Neama. I'm the only participant from Iraq, unfortunately. I joined the movement on March. I applied to participate in the Immunization Agenda 2030 movement. to start with the situation analysis module, and then I got level 1 certificate, and I moved to the impact accelerator to take some action, and here I am.
So what's your priority challenge, Ahmed?
My priority challenge is the drop down in child immunization program, especially in Iraq, especially in the past 2 years, due to the pandemic and the vaccine hesitancy, fear of visiting the health centers. So my situation analysis was about it was at district level about the drop down in annual coverage of the child immunization.
Okay, and Ahmed, can I ask you, how has your participation in the movement changed you? I know you've prepared responses, you've thought through responses to a number of more detailed questions, but for the sake of time and to hear as many voices, can we skip to question 3? How has your participation in the movement changed you in the most concrete ways possible?
Exactly. To make the long story short, participating in this movement, it's not only about the modules and activities we follow up, the online platforms to learn from, but also to gain more skills and knowledge from experience of other colleagues. In the first session I participated in, I remember, Rida, you mentioned that you are not alone. It was like one of the things that kept in my mind, that we are not alone, even if we are in Iraq or any other countries, that we have colleagues from all around the world working together. So I had twins to each module to discuss our priorities, our daily challenges, and how we can move forward. So it was like a great valuable add to my career, and also I learned by doing. Everything was there on the modules and on the platforms. There is a lot of ideas I learned from, and also I did it during my daily tasks. Thank you, Rida.
Thank you, Ahmed Yema. All right, Charlotte, I'll put the questions back into the chat for those of you who are in the Zoom studio. Go ahead, Charlotte.
Right now I'm inviting David Beru. David, your mic is already unmuted. Over to you.
Okay. Hello, everyone. Davis Beru from Nigeria.
We hear you loud and clear, Gold. Please go ahead. Don't forget to introduce yourself. When and why did you join the movement? What's your priority challenge? And how has your participation in the movement changed you? If you can answer just these 3 questions.
Okay. I joined in March when it started. And I'm a medical lab scientist and a public health officer. And joining the movement has been very interesting. Walking through from that March till now, it's been interesting. I've learned so much. And to go to the questions, I've said when I joined, and then my priority challenge was vaccine hesitancy among remote community dwellers, mostly among private health facility users, like all these private maternity homes. And with the priority, that was actually what I developed in my analysis.
Yep.
When we did, and then I followed on. So after the situation analysis, we followed on with the action plan.
Yes.
And
yep.
Up to the implementation. And I must say that most of the things we learned, from the ideas engine, I learned a lot. I had a lot of ideas on how some people that have similar challenges, how they handled it, and some ideas also on how to handle the challenge also on my own side. And then with the last one, that's the responsive feedback, it was very useful while implementing the action during the last few weeks that we did. And I must say that the program has been very good, and I saw changes. I saw a lot of people accepting vaccine, and one of the problems they had was query on the safety of the vaccines. So with the knowledge, because during the action, we had a lot of head talks and a lot of teachings. So they have gotten knowledge, and many of them have accepted the vaccines. Many of them have accepted that it's safe for them and are willing to take it. So it's been a good work all through.
All right, thank you, Gold. That's a great first testimonial. Charlotte, I see many hands raised. So for all of the contributors and especially the speakers, please know that we will share with you the mechanism through which you'll be able to share your story. Even if you do not get to speak during this short session, your story will then be shared with all of the more than 12,000 people registered for Teach to Reach 6. Charlotte?
Yes, Reda, we have Dr. Martin Mayen, whose mic is already open. And then after that, for the sake of respecting our rules of fairness and equity, we'll turn towards Dr. Isha Goyal. So, Dr. Martin Mayen, over to you.
Okay, yeah, welcome. Thank you. Welcome, colleagues. And I'm so happy to really be part of the process up to the end of it. It was so difficult in the beginning, but I think it went on very, very smoothly. My name is Dr. Martin Mayen. I'm from Republic of South Sudan. I sit at national level supporting on data and coordination. So I joined the movement on the first day during the launch on March the 7th. And actually, I was hearing about the immunization agenda 2030, which I was not so familiar with. What does it mean and how does it help me? But I knew it was something to help improve the coverage, reach children, reduce the outbreaks. And I think that is why I was so motivated really when I got a colleague telling me that there is a movement like this. So I think that is why I joined the movement. And actually the participation helped me to really say, why are we not getting many children being vaccinated in the health facility? So we see that the target population that was supposed to come for fixed sessions within the 5 centimeter radius are not coming. Why? And actually, I think I knew why. And this is what has led me to identify my challenge, why children are not coming to the facility, and which goes around planning within the facility itself and within the county. And one of the missing things which I got was actually the lack of coordination. The facility vaccination is a combination of why we are missing is a combination of missed children, lack of communication, lack of collaboration between the different departments in sharing the information and referring the children from one unit to another. So I think this is the challenge that I took, and I'm happy that by this time, I really know by heart that these are the problems within the facility, especially things to do with the coordination and collaboration and transfer of the children, which is helping in the integration of the services within the facility. Other things are also the private sector, the big number of children going there, but there's no single immunization activity happening in many of them actually. So I think that is where my challenge was lying. And I think with the challenge that I really discovered, I was able now to learn a lot of things, starting from idea engines up to response feedback, with a lot of which I can call triangle kind of connection. I get Monday, General Assembly, I learn a lot of things. I get during the experience sharing and the problems identification and how to get the help from different facilitators and then also myself, when I review the colleagues' inputs and submissions, as I put my input, I also learn a lot of things. How they're doing their things, what are the challenges, how do they turn it around? It helps me also identify some weaknesses which I have to input. And I think through the course of this one, there are a lot of learning that is happening there. And I think this end of this one, when I submitted my work plan, I had a lot of inputs. Actually, like from the beginning, what was be my goal? And I got my goal was so clear from the feedback and from learning and from how people interact with others. The long-term goal, unfortunately, my goal is very long-term, but there are intermediate, goals which I was able to achieve. For example, how do we improve the collaboration within the health facilities? And I was able to talk with subnational teams and who are now, we have identified the forums. County review forums where the health facility people come and they will be presenting if they're really doing the coordination or not. This is a new indicator that we've added, and it has now been urging them to be able to do coordination within their facilities to transfer the children from one unit to another. It's actually a benefit across. We have also identified training, IIP training. If possible, other units will also be part of this so that they understand the benefits of transfer of the children across the different units between immunization and the others. The review meeting and also the state level coordination forums. We have also sensitized them, primary healthcare directors, other partners. I'm happy also to announce that we have what we call officers on training. These are the long-term or on-job training officers who have been deployed up to down the counties, and they have very close contact with the health facilities. So they will be providing a hand-on support to the facility people so that the improvement will be noticed, which I'm sure will also happen. So I think this is where I am. And I'm so happy that I've reached this end. And I think Charlotte and Dr. Reda, if you remember very well, I even thought I'm not able to make it. I had a lot of challenges. I was in transit, I was in Rwanda, and I didn't have good network. I didn't know how to access this
and forum. You did it. Yeah.
And I got your help, and it was very encouraging. You told me, hold on, we're here to help you. And I benefited from really problem-solving sessions that are being held. So thank you very much. I feel very confident now that I have better experience than ever.
Thank you, Dr. Martin Mayen. There's a lot that you shared in there in terms of both your activities and also what you got from the movement and the connection between the two. But I would urge members of the movement to be concise and focused so that we can hear as many voices as we can. Never fear, though, if you were hoping to speak and you have not had the chance yet, you will have your story shared with all members of Teach to Reach. Isha Goyal, I see Charlotte has unmuted you, so I'm guessing that you will be the final speaker to answer the 3 questions about your experience of the Movement for Immunization Agenda 2030. Don't forget to introduce yourself and please get to the point.
Thank you, Reda. Hi everyone, I am Dr. Isha Goyal. I work as Surveillance Medical Officer in the state of Uttar Pradesh in India, which is the most populous state in India. And I have joined the movement because in my work profile, I work a lot in the immunization. And there are so many challenges in my district which I have to overcome. That's why I joined the movement. And my priority challenge was to reduce the dropout rate from birth dose of BCG to the measles first dose, that is MCV first, which is given at the age of 9 months. Initially, before joining this movement, I had the data at the district level that what is the dropout rate of the district and what are the challenges at the district level. But with the help of this movement, as I move forward and develop plan step by step, like from the ideas engine to the situation analysis to the action plan, then I got to know that I have to work step by step and set a goal which is achievable and which should be more specific, which I didn't do before participation of this movement. After I participated in this movement, I become more specific. I set a specific goal and developed action plan according to that. And I am very happy that I'm moving forward step by step. Like I have completed my first action, which I have to be taken in the dealing with this challenge. First step I have developed, was the finding the villages and sub-centers which have the highest dropout rate, that is below the district level. So I am now able to find out the deep root cause of the dropout rate in village level, and by this action I am able to take village specific action, which is helping me a lot. So by the help of this movement, I am able to be very specific and working according to the steps which I am taking day by day. So this is a movement which helped me a lot in this. Thank you.
Thank you very much indeed for this story, Dr. Isha Goyal. We're reaching the end of this session. We know it feels short, but every time we ask you, what's the biggest challenge? That's not immunization. You say it's time. Time is the most precious resource. That is why we keep these sessions short. But every person who is invited to speak in this Zoom studio, your story will be shared out right after this Teach to Reach. We have 5 minutes remaining, and one key step is to actually share with you what will be the next stage of the movement for Immunization Agenda 2030. So you may be wondering, if the first full learning cycle finishes today, of course there will be the certification to recognize and honor those who really made that commitment and were able to stick to it throughout the preceding 16 weeks. But I will give you a very simple answer to this question, is that you will be the ones, as members of the movement, as movement founders, for those of you who started on the 7th of March, we will work with you to co-create, co-design, think through together with you, because this movement makes no sense without you. And this movement is about you as immunization and other primary healthcare professionals, leading the way, making the difference to actually accelerate progress towards the goals of Immunization Agenda 2030. So even if you are sitting alone in front of your computer screen or your phone, I'd like you to give yourselves a big round of applause to really recognize that the next stage of the movement is going to be determined by you. And after 16 weeks, we know who the leaders are. We know who will be there, who will go above and beyond your daily work, your daily duties, in order to contribute to the movement. We know who has made significant progress, who wants to make progress, who has the intrinsic motivation, and will be looking to you as the leaders for the next stage of this movement. We now have 4 minutes left, which gives us time to switch over to the next, to get ready for the plenary session that will be coming, and that is Plenary 1, which we're doing in partnership with UNICEF on building confidence in COVID-19 vaccines. So we're going to go here. Maybe we'll be able to, let me see if we can set the countdown again. I don't think we need it. So let's just go to the music, and then we'll come right back at the in 3 minutes to go into this session on building confidence for COVID-19 vaccines. Thank you once again. There's much to celebrate. Now you'll have to choose between Plenary 1. If wherever you are, wherever you're watching this, you can stay there. So if you're in the Zoom studio, you can stay there. If you're on the stage and hop in, that's over here, you can just go to the stage and stay right there if you want to participate in Plenary 1. If you're watching on YouTube, Facebook, you'll be able to watch and make comments. But there are other options, and that is networking. If you're interested in networking with fellow members of the movement on overcoming a challenge to improve healthcare in your community, in the community you serve, or if you'd like to join the special session on responsive feedback. Now, this is not necessarily for those of you who've completed the module. It is more about, it is more of an intro to what is the module for people who do not know it yet. So you have to make a choice. There are many of you who are spread across the different platforms. We want to meet you where you are, and so you'll have to make a choice between the plenary, how we build confidence in COVID-19 vaccines, networking, and again, a reminder of how you join the networking. You go to, so you first have to get your ticket and all that and hop in, but once you're there, you go to the People tab, and here you can go to Speed Networking, click on Join Now, and click on Join. I'm actually going to demonstrate that here again. So you go to Join Now, just get this out of the way. Start a conversation, and you're connected with, I'm going to be connected with Mary Adomako, a nurse and public health practitioner. So let's see if it works. Yes, it does. Okay. Hello, Mary. We're actually in Plenary. It's a pleasure to connect with you. We're actually sharing with everyone who's in our Zoom studio and across the different social media channels. I just wanted to make one last demonstration. I will connect with you and then have to leave this to go back to the plenary. Thank you so much. All right, and we're now 1 minute away. We're going to go back to the countdown for this first plenary. If you're interested in this question of COVID-19 vaccination, stay right where you are. Don't go anywhere. If you want to network about a challenge and understand how others are overcoming their challenges, go to Network Now. And if you're interested in responsive feedback, you should go there as well. All right, here we go. We are now at time. And so we will... Warm welcome to you from Geneva, Switzerland. This is the first plenary of 3 main plenary sessions at Teach to Reach 6. And our topic today is how we build confidence in COVID-19 vaccines. It is not about bemoaning the lack of confidence in vaccines. It is not about talking how terrible it is that there is vaccine hesitancy or how convincing disinformation and misinformation have been in the face of COVID-19 vaccines. We're very proud to be doing this this session in partnership with UNICEF, and we'll be introducing our guide on the side for today's session a little bit later after we have heard at least 3 stories that are shared. So we are interested in something very simple, and we're interested in what is it in your practice that you are doing that is actually helping you in the field, in your daily work, to build confidence in COVID-19 vaccination? So we'd like you to share your experience and also consider this question. Do you think others could do the same as you? And then we have a more, let's say, a more comprehensive set of questions that that we'd like you to think about. Is really think about a time when you helped someone, a colleague or a group. It could be a colleague, could be a caregiver, who knows? You'll tell us. And you help build their confidence in COVID-19 vaccination. So I want you to describe the situation, explain what you did, talk about the outcome. How did it turn out? Reflect on why you think it worked. And then also think about, like, for a colleague facing a similar situation, but in the same problem, but in a different context, do you think that what you did could work for them? So that's what we're going to focus on in this session. But if you are interested in networking how you and your colleagues are overcoming challenges that in ways that actually improve healthcare, you can go to Networking right now. And if you're interested in learning about responsive feedback, we have 3 parallel sessions, so you will have to make a decision, a choice about which one you are most interested in. So let's kick off. Again, we want you to share what strategies are actually helping you. I'm going to turn to my guide on the side, Charlotte Mbou, and let's say mistress of ceremonies, to lead us to the first speaker to hear, who will share their story of overcoming COVID-19 vaccine hesitancy, strengthening vaccine confidence. Charlotte?
Thank you, Reda, and with much pleasure, our first speaker is already unmuted. I'm inviting Prof. Becky Tagbo to share her experience with us.
Yeah, thank you, Charlotte. Thank you, Reda, and the fellow scholars. I have a lot of success stories to share in terms of building confidence, especially in COVID-19 vaccination. I'm going to share maybe 1 or 2. I'll try to make it brief because I have so many. I had introduced myself earlier in the previous sessions. By God's grace, I have a lot of social capital that makes people have confidence in me. And so I leverage on that a lot. I'm the chair of the WHO Advisory Committee on Vaccine Safety. I also work with the WHO Geneva Global Advisory Committee on Vaccine Safety. I am also a professor of pediatrics and vaccinology. I am an immunization field expert. And so all of these give me a lot of advantage. Of course, I've done a lot of research that shows that people have a lot of confidence on health workers when it comes to looking for information on vaccine, and especially.
Of course, we're glad for this extended introduction. Can you think of a time when you helped someone and that actually sort of changed the day? And I believe you have a very, very impressive specific story to share.
Okay, so one of them is during the impact acceleration, project, the action plan. So I decided to work on the staff in my institute because my institute administers vaccines. So I decided to do a very quick survey. This is what everybody else can do. Just in your small unit, I used the WhatsApp platform. I formed a WhatsApp group and then sent out an online questionnaire to find out local and their own specific reasons for not taking the vaccine. And I asked also how many had taken the vaccine. And surprisingly, it was below 30% that had taken the vaccine. And yet this is a vaccination site, so you can imagine. And then I also asked them, it was open-ended question, what is your own reason for not taking it? And I was able to find out their own specific reasons. And the next step was to find credible information that was targeted at their very own specific reasons. And I started sending out these messages on that WhatsApp platform, why they should take the vaccine, how that it is safe. And those messages had logos of credible sources like the WHO and the federal government. And before you knew it, they were already responding that they didn't know all of this, and they were ready to take the vaccine. And within 2-3 weeks, already they had changed their mind and they are going to take the vaccine. The other one was in my religious organization. I had to talk to them, and I also told them that I had taken the vaccine, my family had taken the vaccine, and the moment they learned about that, they even did not just take the vaccine, they went on the social media to display their card that they were proud to have taken the vaccine. And these were people that were opposing the vaccine initially. So everyone can implement this in their place of work. Thank you, and over.
Remarkable story. Thank you, Professor Bakitagbo. Again, keep in mind as you speak that there are many of you who wish to share your story in the room. Charlotte, who shall we hear from next? And please do raise your hand if you are going to share, if you have a story to share.
Reda, I'm inviting Hilary Okello. Are you able to unmute yourself? Hilary Okello from Uganda. We are trying to respect geographic and gender equality.
Yes. Thank you very much, everybody.
All right. Unfortunately, Hilary Okello, your connectivity is not holding up today.
Yeah. Thank you very much, everybody.
Yeah. All right. Sorry, Hilary. We have a mechanism planned for this, which we haven't shared yet. But it's obvious that your connectivity is not holding up. This is unfortunate. But we will go now to the next speaker, Charlotte. So
we'll listen to Bile Nestor Binka, and then hoping that connectivity is on your side. And after him, we are going to listen to Lulu Bravo.
All right. Bile Nestor, the floor is yours. Tell us of a time when you helped someone, an individual or a group, to build their confidence in COVID-19 vaccination. Please get to the point, focus on the specifics of a story so we understand it and that others get to speak as well.
Yeah, thank you very much, Reda. Thank you very much, Charlotte, and good afternoon to everyone. I'm Dr. Bile Nestor Binkar. I'm the District Medical Officer working in the Northwest region of Cameroon in Kumbu East Hair District. Talking about building confidence, COVID-19 vaccination. Actually, I had a situation in my health district when we started the vaccination campaign or vaccination against COVID-19. So when the vaccine was brought, there was a lot of hesitancy, especially with the health staff. So it was really a difficult situation for me because my personnel did not even accept the vaccine, and it was a challenge. So I took upon it, I decided to act So I was the first person who really took the vaccine in my district, and I tried to find out what was the problem, because the main problem I discovered was coming from the health personnel and also from the community. So I discovered there was really lack of knowledge, and there was a lot of intoxication from social media, misinformation. People tend to believe in messages that we are not actually true. So what I did is specifically I engage with the advocacy, and with the advocacy, my first target was we are the health personnel. So I targeted the health personnel. I gave them information, used to sensitize them, give them information from credible sources, from WHO, even present data from countries that have done a lot as far as vaccination is concerned, and their outcomes from those countries. With much knowledge, they decided they understood everything about the vaccine, and many of them started taking the vaccine. So I also engaged with advocacy with the religious and traditional authorities, and this helped a lot to influence the rate of acceptance of vaccine, of COVID-19 vaccine in my community. Then when my health personnel were already convinced, all of us engaged with community sensitization, and this really helped to boost the level of acceptance. And to tell you now, we are really doing a lot. We are one of the best performing districts in the northwest region of Cameroon as far as COVID-19 vaccination campaign is concerned. So we think that I want to think that advocacy is very important. Many people refuse this vaccine because of lack of knowledge, and when we give them the right knowledge, they tend to accept the vaccine, and they become ambassadors of this vaccination. So we have had a lot of success stories, and we continue to record more successes. Thank you very much.
Thank you very much indeed. All right, we are going to hear one more speaker, and then we will turn to our guides on the side. So very pleased to share that UNICEF is our partner for this Teach to Reach, and right after, within a few days after Teach to Reach on the 2nd and 23rd of June, there will be a international global event on COVID-19 vaccine demand. UNICEF and other global partners, including the Geneva Learning Foundation, will be there. This will be a high-level panel featuring ministers and heads of global and regional agencies. We'll be hearing from Deepa Pokarel, our guide on the side, who is a very senior, very experienced with vaccination demand issues, who's listened to Becky, who's listened to Nestor, and they'll be listened after hearing one more speaker. We'll turn to her as our guide on the side and ask her to share her reflections. Now, some practical information about this upcoming global event is that all Teach to Reach participants who share their story about COVID-19 vaccine demand will receive an invitation to join this summit, this global event on the 22nd and 23rd of June. Back to you, Charlotte, now for one more speaker before we go to our guide on the side, Deepa Pokarel.
Okay, Reda, Lulu Bravo from the Philippines already has her mic open.
Okay, wonderful, and a warm welcome to you, Lulu.
Thank you, Reda. Thank you, Charlotte, and thank you for this opportunity. You know, I listened very well to your podcast, and years before, or actually when the COVID struck, we came up with a podcast. And we were talking to people. Oh, by the way, I joined your March 7 from that time on. I learned a lot of things that told me that just lecturing or just getting people to be informed about data is not really enough. What we have is what you have been doing is sharing their stories. So what we did is I would look at their Facebook entries and pick those people who have made beautiful comments or made their situation analysis on Facebook, right? Because I didn't realize that can be done.
Right.
Now I listened to what you have been doing, and we can see how people became more engaged, became more active to do more things to improve vaccination when you listen to them, when they tell their stories. And I have one mother, and it was on Mother's Day last May, when she told us that she is hesitant because she's elderly, she's 80 years old, and she's afraid that, the vaccine, COVID vaccine might not be good for her. But then after telling her, as Dr. Tabu there mentioned a while ago, when you ask them that, I'm 72 and I have a 90-year-old friend who did get the vaccine. And so she said, okay, I'll probably try that. And true enough, these mothers and elderlies whom we are talking to every so often are able and willing. And during this time, we are able to open up their conversation because we send them the Zoom link, just like what you're doing now. And this is what helped us. And what I really want to do is to set up something like your kind of activity in an Asian time. Because much as I would like people to be able to reach out and talk and engage, this time is really terrible for the Asian.
So Lulu Bravo, it sounds to me like you're interested. You want to start the country team, the Philippines team for the movement, the IA 2030 movement, which does not currently exist. So I think if that's
this is exciting.
You are. I know you're already a national leader in immunization in the Philippines. Would love to discuss this further after we go as we connect. And yes, there are new opportunities, new ways to connect that enable new ways to learn, new ways to lead change. And that is, I think, what we are both interested in, Lulu and many members of the movement. And now I'm pleased to introduce you to, actually, she's going to introduce herself, Deepa Pokharel from UNICEF, who is our partner for this plenary and for Teach to Reach, in fact. And Deepa, please do introduce yourself. And then you heard 3 stories from Becky Tagbo, from Bile Nestor and Binkar and Lulu Bravo. We'd love to hear your reflections, your thoughts in response to their stories. But first of all, a warm welcome to you.
Thank you, Reda. Really, it's so privileged to be among colleagues who are doing such wonderful work. And all 3 colleagues, what really struck me is the efforts that they put in to really understand their communities and come up with really simple measures on what is going to work in that particular context, because vaccine hesitancy can be very context specific, it's very personal, and it may have a myriad of reasons. It's very easy to put it in a very loose bucket to say that when nothing is working, it's vaccine hesitancy. But sometimes the vaccine hesitancy are very real. So it could be an access issue, it could be not being able to register, it could be that the social norm and anything. But what I really liked about the 3 colleagues who shared the stories was it was very simple yet very innovative. And we all know that I just picked up the last speaker's comment on listening being so important. And that's exactly what we are seeing from the different countries across the world, that when you listen to what people's concerns are, what is their fears, and what can we do to really provide accurate information. And that was exactly what was done in the WhatsApp group. So first listening through a very simple survey, then giving them accurate information was really, really very interesting to me. And also about what the health worker himself has been a role model by walking the talk is a very powerful tool for creating a social norm, but also influencing others. And the third, it was really very personal how you are motivating starting from the home, listening to your mother. And that is going to be a very personal thing for you. And I think these personal stories, which the TGLF provides us to share, listen first to colleagues, and stories are a great way of actually putting a motivational element to what we are trying to do. So thank you very, very much, Reda, for the opportunity. And thank you, colleagues, for sharing the stories with us. We hope to see you on the global event on the 22nd and 23rd, where a lot of these lessons learned from different parts of the countries are going to be shared by many people across the world from different partners. So thank you so much.
Thank you very much indeed, Deepa. And back to you, Charlotte, for our next speaker.
Thanks, Reda. I'm inviting Obina Chukudebe, whose mic is already unmuted. Over to you, Obina.
Yeah, thank you so much, Charlotte and Rada, for inviting me. I'm very excited about this. However, I think one of the major informations that informed our strategy
Please, can you
in
start by
addressing
introducing
hesitancy.
yourself?
Oh, thank you very much. I forgot. My name is Obina Chukudebe, and I'm currently the immunization policy manager in with Sanofi, one of the vaccine manufacturers. One of the factors that informed our strategy was I'm sure most of us must have seen it, the CDC research result on physicians' recommendations being key, a key driver of vaccine uptake and acceptance. And I'm sure if just to reiterate, it showed that with a positive patient attitude and a physician's positive recommendation, 87% of patients get vaccinated, while with a positive patient attitude and the physicians not recommending, 8% will tend to get vaccinated, which is very low. And we discovered this, and then it informed our strategy to address the concerns of healthcare professionals like nurses, pharmacists, doctors on vaccine uptake, and to address questions like, do we really need this vaccine? Is the disease really debilitating as it sounds? Can vaccine administration lead to death or other defects? Why do some people still come down with the illness even after being vaccinated? How safe is the vaccine? So this further trickled down to we coming up with several mediums to close this gap, which number one was involving credible experts to share their opinion. Just like Professor Tagbo said, she's one of our very key respected experts. And then in organizing nurses training on vaccination, doing a refresher for pharmacists and doctors on vaccination, supporting expert-led presentations at high-level scientific conferences, distribution of IEC materials to raise awareness on patient education, and then working with the MOH to increase awareness through World Disease Days and the likes. So where we reminded ourselves in these forums of the overall value that vaccine have brought, before even pre-COVID-19 era into the world of humanity. So I think after this whole project, which we are still involved in, it has really helped in upscaling vaccine uptake in our country, specifically in Nigeria as a whole, and we are still growing. And thank you once again for the opportunity. Charlotte, over to you.
Thank you, Obina Chukudebe. Charlotte, we go to our mistress of ceremonies.
I'm inviting Alta Samaila outside. I may at times the names kind of like and don't enable me to determine, in terms of our fairness as far as geography is concerned. But Alta, I don't know if you're able to unmute yourself. After Alta, we can turn to Gift Akosua. Alta is not unmuting Reda, so I'm inviting Gifty Akosua. Are you able to unmute yourself?
And yes,
hello.
She is.
Hello.
Welcome, Gifty. So don't forget to introduce yourself. And we really want to get specific. It's not sharing vague generalities about vaccine hesitancy. It's really a specific time, a situation when you did something that helped move an individual or a group build their confidence in COVID-19 vaccination. Over to you, Gifty.
All right. Thank you. Thank you. Good afternoon. Good evening to everyone. It's a great privilege to be part or to be called this afternoon to present. I'm Gifty Akosua. I'm public health nurse from Ghana, and I formerly worked with a health center, Noguchi, but recently has moved to the District Health Directorate. But still, I do work in the community. When I joined the immunization agenda 2030 in March, I would say I've learned a lot, because my challenge was with people with speech and hearing impaired. We are saying we don't want to leave anyone behind, but when we look around, we realize that people of such are left behind, because most of the time they are left in the rural areas or left by themselves. So in my district, I am the only nurse who does the interpretation or who can interpret using the sign language. So looking at that, or knowing that they are being left behind and they don't know what COVID-19 vaccination or immunization was all about, I took it upon myself to join, or I was introduced by somebody, actually, one of my bosses. So I learned a lot from the experience that was shared by other people, only to even realize that people from Ghana even have a team already. I was so happy. So I joined an NGO, and that was when we had our first meeting with the people with speech and hearing impaired. I got the opportunity to speak with some of the bosses from the NASLIC, that is a National Association of Sign Language Interpreters. And to my surprise, we realized that most of these people with speech and hearing impaired were not having phones. And those who were having their phones were getting information, or let me say, some rumors all about the COVID-19 vaccination, whereby they were scared. If one question was like, if they cannot hear or they cannot speak, if they should take the COVID-19 vaccination again, what is going to happen to them? Are they going to die? How safe is the vaccine for themselves and their children? And I have to explain all this to them with demonstrations, because you know that most of them to have not been to school. So you have to use the natural gestures for them, and also continue with those who have been to school. I mean, you continue with the normal interpretation for them. And it was not easy. We have to move far and near to some rural areas for home visits, just to trace all this deaf and dumb in their communities with the help of the chairman. And I would say it was a great privilege to know most of the areas. And I would say the positive outcome is that about 25 of these people, I mean, the speech and hearing impaired, have been vaccinated, because they've now understood that COVID-19 vaccine is safe, and that when they take it, they are not going to die. And it's not going to cause any more harm just because they are already having a speech and hearing impaired is going to cause more harm. No, it is really safe. And now even the chairman has taken it upon himself that he is going to take me to any new deaf and dumb that is going to come into the community that we don't know about. He is going to take me to the house, and we are going to vaccinate everybody in the community.
Gifty, thank you for sharing this story. We'll be turning to our guide on the side, Deepa Pokral from UNICEF, to share her feedback, her insights on the challenges of reaching vulnerable people with COVID-19 vaccines, including the community you described. Back to our mistress of ceremonies, and never fear if you do not get, this is a very short session because we know how pressed for time you are. We know many of you have to go back to your daily duties right after this session, but every story that has been shared in writing will be shared out to the full list of more than 12,000 participants of Teach to Reach, so you will be heard even if you do not get to speak today. Charlotte, who shall we hear from next?
Thank you, Gifty, for that story. I can't go back to Nigeria. I'll have to move to another country and another gender. That's why I'm inviting Kelvin Siafa Boima. Sorry, Dr. Ndayo. Kelvin Siafa Boima. Are you able to unmute yourself? Your hand was raised.
Yeah, hello.
Yes, Kelvin, we hear you.
Please start by introducing yourself. Yes. We can hear you.
Yeah, I'm Kevin Shefa Buema from Liberia. I work in a sub-national area supporting the country health team in the implementation of the COVID-19 vaccination activities. I'm an epidemiologist by profession. I work for WHO. So at the inception of the introduction of the COVID vaccine in the country last year, April, a lot of hesitancy, a lot of refusal. So we introduced it in Maryland, where I'm working, providing support to the country health team. It was a challenge. So we decided to do a visit to the community and find out what are the issues, what are they afraid of. In fact, COVID affected the entire world. So we went to one of the towns, had a focal group discussion with them. Their own fear was a vaccine was brought to kill them. And why are the children not taking the vaccine? So to answer the question, we'll put it right back to them. If you think they want to kill you, are we going to be going through vaccine? Why don't you bring a truck of rice and pull it far away and ask that the first person to get to the truck, you get 20 bags. They also will run for it. We'll say, but then That's why we are telling you that it's not what it needs, that they want to kill you, they want to kill you, use that medium to kill you. This medium for all to put our hands together to fight the deadly disease and causing problem for us now. So bringing the vaccine help us to protect you, protect us, and protect the entire population in Maryland, Liberia, and the world at large. So for children, they will gradually go down to the level of the children. So we discuss from one thing to another, we're able to bring down to the knowledge that yes, they got to understand that yes, we are there for them. We have been there for a period of time, giving them service again and vaccination. We took another vaccine like measles that have been given to their children and sent the vaccine how it was there with us. We explained to them the detail why it was for. When we got through, they all said, but then no need for us to be afraid. They gave in, and we were going. We carry a vaccine with us, the COVID vaccine. As soon as they accepted our strategy, we begin to vaccinate them. And for those that took the vaccine, when we introduce it, we share our card. And to vaccinate them, we get a card. From there on, as the strategy we have been using, going through, as we stand now in Maryland County, our coverage for fully vaccinated is around 41%, and for partial around 75%. So we are gradually moving on and using the same mentor, going from one house to another, engaging the community and the individuals to have them get vaccinated. Thank you.
Thank you very much indeed. So Charlotte, before our next speaker, we're now going to turn to our guide on the side for this session, and that is Deepa Pokharel from UNICEF. You've heard 3 additional stories from Obina Chukwudebe, from Gifty Akosua Zigbe, and from Kelvin Siafa Boima. 3 very quite different and distinct stories. What are your thoughts, your reflections, insights? What could you share back with these speakers as well as to the other practitioners in the room, many of whom have found practical ways to build confidence in COVID-19 vaccination? But can you help us figure out what are the right ways, what are the best ways, what are the recommended ways, and to what extent is at least some of it left up to the creativity and local adaptation of individual health professionals? Over to you, Deepa.
Thank you, Reda. Sorry, I forgot to introduce myself. Actually, my name is Deepa Pokharel, and I'm the vaccine immunization team lead for UNICEF, based in New York headquarters. So I work to guide the regional and country level colleagues on the vaccine confidence, together with a wonderful team that we have with partners. So just going back to the 3 stories, as you said, Reda, they were extremely distinct but very relevant, because what we are seeing a couple of things, like, how do we reach the vulnerable communities? That was a very powerful one. That is also at a global level. This is the discussion that we are having. Health workers as not just as the recipient of vaccination, but also very powerful communicators as credible source of communities. And then what could we do to co-create local solutions with the people, which came out very nicely in the last session. So on reflection of the 3 stories, how do you reach the vulnerable communities? I think that was very interesting. And this is something which is very unique, what the colleagues shared about how do you reach to the speech impaired people, and to really, because they are not able to speak, neither hear. So I think that we do need to prioritize from the planning cycle itself. We need to make an extra effort to reach out to them. For that, what we can do is to really work with colleagues like yourself and the organizations which may be having access. Then you give a very specific story about the speech and hearing impaired people, but it could be others like blind people, or it could be other, not just the disabled people, but also people living in refugees and camps and elderly population. What we need to first do is to really listen to them. What exactly are the specific concerns? Is it a mobility issue, or is it that they are guided by misinformation, or is it that they are not feeling comfortable? Because it came out through all the 3 areas that they had a fear in getting vaccinated. After listening to them, then just co-creating with them, listening to them and providing them accurate information, but also giving the information through credible source of information, which came out in the first story. Health workers are the credible source of information, walking the talk, which was also in the first 3 questions. questions which came. But I also actually was very intrigued to listen to the success there of the last speaker, in which one area seems to have 75% coverage, with another one having 41%. What may be possible perhaps is to consider whether you want to see what has worked in that 75% and what was the triggers that really made people understand what has worked. I think at the end of the day, the message is clear. Listen first, and then come up with the accurate, technically accurate messages, and then do the interventions with the communities and measure success. That's going to be quite a simple way of putting it together. But I just wanted to say one thing. We've really moved away from IEC material, from all areas of communication work. IEC material is great as a visual material, but I would suggest that and encourage colleagues that we put more efforts in more local and community engagement, talking to people, mobilizing other people of like-minded people, and also using your local radios. It could be simple things at house-to-house visits. So I think I just wanted to bring in that. Yeah, Reda, over to you.
Thank you very much indeed. Deepa Pokharel from UNICEF, who is part of the team leading the global event on COVID-19 vaccine demand that will be taking place on 22nd, 23rd of June. She is today our guide on the side, will no doubt be presenting at this global event. And I'm pleased to say that through the partnership with UNICEF, we want to invite participants who are at Teach to Reach. We'll be asking you to share your story if you have not already. If you have shared your story, if you're one of our invited speakers, you'll automatically receive an invitation to this global event. If not, you'll get a chance to share your story after the event, after Teach to Reach today, with a very short deadline because the event is happening on the 22nd and 23rd of June. I highly recommend you pay attention to the incoming emails. We know we've sent you many of them, but take the time to read this one so that if you're interested in this issue and want to access the best available global knowledge as well as contribute your experience and expertise. Having said that, back to our mistress of ceremonies for the next story we're going to hear.
I'm inviting Rukindo Kebi Margaret. Rukindo Kebi Margaret, are you able to unmute yourself so that we get to hear your story?
Oh, thank you so much. Can you hear me?
Yes, Rukindo, over to you.
Oh, thank you so much, Charlotte and Reda and all colleagues in the house. I'm called Margaret Rukindo, and I'm a nurse from Fort Portal, Uganda. Mainly, I deal in immunization services at community level, facility level, and also at district level of city. Mainly, the biggest situation we faced as a city was the low uptake of vaccination, COVID vaccination by the healthcare workers. And actually, we had just started this service and the uptake was so low. The healthcare workers were so hesitant about taking up the vaccination. And so it wasn't easy. That was a very rough time when we had so many cases of COVID, and then it was kind of a break in the healthcare services to the cases. And then we realized that was going to be a big mess. And then we went on the ground, and then we realized that the cause was about lack of information and also fear of the side effects of the vaccine. And also the main one was about that as it was announced that the vaccines were being used as an emergency, they were lent as for emergency use in the community. So that was not so much clear to everyone. So mainly we went into sensitization of these health workers, giving them rightful information. We used the experts. We gave testimonies for those that some of us had taken these vaccines. So we showed them the cards. We talked to them, and then even other experts talked to them. Then we told them not to follow the social media information, which was really giving them misinformation. And then we also giving testimonies worked so much for us. And also most leaders had their jobs, and then even the leaders in the healthcare workers had their jobs, and they waited, and then they saw things were moving on well, and then most of them decided to take up vaccination as well. So we really saw people start coming for vaccination after intensive, of course, education, mentorships, then going to the facilities down to mentor, to give information. We made a team to visit these facilities so that we are able to talk to these healthcare workers, and it really worked for us. Just in a quarter, we realized that as a city, we were moving from around 15%, and within 3 months, we had gone as far as the 65%. So we saw we were moving, and as I talk now, we are at 90% vaccination of the healthcare workers. What I would recommend is that it needs teamwork. It needs to engage these health workers at every level, planning, implementation, and more especially with mobilization. So those that have been vaccinated, it is so easy for them to give testimonies, and then to sensitize, to sensitize the communities also about the side effects and how we manage the side effects of these vaccines. And then continuous sensitization, continuous giving timely information, and also recommending them to have credible sources of information where they get this information from, and also keep building the capacity of ourselves, our own selves, and also other people down there to get knowledge, more knowledge about the vaccine. As I talk now, there are courses about vaccinology, and some of the health workers, most people have taken up these courses. So there is a lot of building on the capacity building, which is going on, and it is working for us. That's what I can really give over to you, Chair. Thanks so much, everyone.
Charlotte, I believe that's you. And thank you,
Thank you very
Margaret.
much. Thank you very much, Margaret. And I also want to thank Fam Ufoma and all the others that are sharing their experiences in the chat. Rather, I would like to go towards Asia, India. Jimli Barua, are you able to? Okay, your mic is already unmuted. Let's hear your experience, and I hope Ndayo Iwot will be able to succinctly share his own experience before we move forward. Over to you, Jimli.
Thank you, Rita, very much, and thank you for this wonderful platform to be able to share the India experience. I'm Jimli Barua. I work as a social behavior change specialist with the India Country Office, UNICEF, and currently I'm posted in a state. And I've been working in immunization for a very long time in the area of behavior change communication, and particularly with the routine immunization program of this country, and have been responsible for several new vaccine introductions in this country. I'll just talk about the COVID experience that I had while working with the Ministry of Health and Family Welfare. In 2020, I was part of a UNICEF team of experts who was mandated to work with the Ministry of Health in developing the communication strategy for COVID vaccine introduction in the country. The situation at the time was rife with a lot of misconceptions, worries, anxieties, a lot of myths were going around in the media globally, in the country as well. And people raising their doubts and anxieties about this new vaccine that was being developed. So the strategy development process began way before the vaccine actually came into the country. So we started pretty early under the guidance of the ministry. And based on the past experiences that we have had with introduction of new vaccines in this country, where vaccine hesitancy had always reared its ugly head from point to point, from time to time. We took into consideration all those experiences and built on that a very, very strong, a very, very robust and a comprehensive communication strategy, which is a 5-pronged communication strategy with pillars on advocacy, capacity building, AFI crisis communication, social mobilization and community engagement, and media engagement. So among this, I will particularly add my experiences, particularly from the UNICEF point of view, and how I worked with my colleagues on social mobilization, community engagement, building and bringing in the experiences countrywide, global, that we have on risk communication and community engagement. Those are the principles.
Hi, Jimmy.
Yes.
I'm sorry for interrupting you, but can you just share with us maybe one case, one particular story?
Yes, I'm coming to that. Yes, I'm coming to that. So on community engagement, what we did is that we engaged with community-based platforms. That is community-based organizations, group of influencers and youth organizations in this country, and through digital media, because we were in a lockdown at the time, so we couldn't reach out to them physically. So we made use of the digital media, that is Zoom, Teams, and the mobile phones, because we have an extensive coverage of mobile phones in this country. So we reached out to people with messages, accurate, timely, and consistent messages on the vaccine and on COVID appropriate behavior, reaching out extensively. And that really helped in building our enabling environment and a positive environment around the vaccine. So by the time the vaccine actually got introduced in January, the fog of hesitation and hesitancy that we saw in the earlier phase, that was much, much reduced. And what we continued to do was that we continued with these strategies consistently, and keeping it up even when we introduced the vaccine cohort by cohort. And that is what really had worked for us. And particularly with the media, we had a national media response cell in the ministry, which continuously gave out consistent and correct information out to the public. And there was a toll-free number. People could call out and reach out people directly, the officials in the ministry directly. And that is where we work very closely with the ministry, the UNICEF team. And we found that these were the strategies that were really, really working, and people were slowly coming out of their, hesitancy, the anxieties, to come out and take the vaccine, accept the vaccine. So this has been a good learning for us, and we also built in, like Deepa said, another aspect that we brought in was listening to a lot of people through social listening. We continuously did a lot of studies, and particularly listening to young voices, listening to the target audiences, and hearing the perceptions, hearing the experiences, and bringing them back into our activities. That really helped us in building people's confidence on the vaccine. So that was a big learning, and of course there are many things to share. So this has really worked, and as of now, as I speak to you, there's the door-to-door vaccine campaign happening across the country, where our healthcare workers are going to every household to ensure that all the people are, eligible people are vaccinated with the doses of the vaccine. And as I think by now, as you know, globally that we have, crossed over 1.9 billion doses of vaccines, and almost 89% of our country's adult population is vaccinated with the COVID vaccine. So that is the range of success that we have been able to reach consistently working with the government. So thank you very much for giving me this opportunity to share this experience.
Thank you, Jimli Barua. Yes, indeed. Thank you very much indeed. Now we are going to hear one more speaker and then turn to our guide on the side, Deepa Pokharel from UNICEF, to share final insights and comments for this plenary session focused on how we actually are building confidence in COVID-19 vaccines. So not generalities or abstractions, but the concrete work that is being done on the ground, whether in the facility, at the district, region, or state, or at the central national planning level. Mistress of Ceremonies, Charlotte Mbu, back to you for our ninth speaker in the session.
Thank you very much, Reda. Nayo Iwad, your mic is already unmuted. Over to you.
Thank you, Reda. Thank you, Charlotte. Thank you all the professional, global professional on the side and everybody else. I'm Dr. Iwad Ndayo, Abuja, Nigeria, and I joined the movement in March 2022. I've been involved directly with immunization strategies implementation at service provision level, and 20 years at policy, guideline, and development, 10 years. And I remember vividly an occasion, this is an occasion that felt needs of the target population were addressed, could enhance coverage. And I want to present this occasion at this moment. So I had to help a group of resident households in a circumscribed low-income underserved community of Kayada Kasa in Kuje Area Council of the Federal Capital Territory of Nigeria, to overcome their initial reluctance about oral polio vaccination only during supplemental activity vaccination campaign. This was before the COVID-19 pandemic, when we had a national immunization days plus in February 2020 as part of the strategies to eradicate the wild polio virus. This is a location with a total population of 300 people on micro plant, under 5 population of 60, and pregnant women of 15. The social relation team lead in the area council during evening review meeting had presented a social relation report on day 2 of a 4-day implementation period, that this particular settlement has been rejecting vaccination during campaigns, but have their children fully immunized on routine immunization in the nearest PSC facility, as confirmed by vaccination cards. He decided to present this report for further intervention, as previous efforts at resolving the hesitancy failed, and that their reasons were based on unrealistic condition that free treatment for other diseases be given before they would allow vaccination of their 5-year-old children with oral polio vaccine. The evening immediately after the review meeting, I met briefly with team consisting of the vaccination team supervisor, the World Health focal person, and the local immunization officer on the possibility of deploying a health camp team to the community the next day. That is the 3rd day of implementation. But we had to meet with the community for further arrangements at home at Kayada community. That we were able to receive, and we were properly received, and we brief meeting with them and the elders. We got the assurance that they would comply on the fact that other local health illnesses conditions would be treated free of charge, as the people were poor. I explained that vaccines were not free, as huge sums in US dollars have been spent by vaccine partners to support the eradication of the wild polio virus, and that governments had a duty of supporting the vaccination program with logistics to teams for the exercise. Since this is a task that must be done, we had to take the vaccines from house to house, and among other strategies to ensure eligible children were vaccinated to boost herd immunity to at least 90%. With this, paralysis of our children will be averted. The information was passed on to the caregivers on day 3 of the campaign, when the continuous health education and prevention of local diseases and treatment of sick residents, free treatment of under 5 and provision of free antenatal services were implemented in the territory as ministerial policies, and they were encouraged to demand for services and report challenge through some assigned functional phone mobile numbers. I wish to reflect that this health camp approach at resolving vaccination hesitancy and to boost vaccination coverage is recommended by the National Immunization Guidelines for economically poor, low-performing, understaffed, far-to-reach, and non-compliant communities. It should be a standalone strategy. It could be a standalone strategy at resolving vaccine hesitancy, or in combination with other strategies in context. The approach was apt, and in context, resolution of the issues of vaccine hesitancy was 100%, as all eligible children were vaccinated. In this context, the approach could be applied in any region globally with good results. I advise colleagues facing similar situation to adopt this approach, The cost of equipping a health camp is minimal, as local diseases on the integrated disease surveillance and reporting tool are presented. The essential medicine stock could be used, or some funds on incidentals from the ongoing program could be used to procure some essential medicines to resolve localized hesitancy in the context. Trying to apply this approach in a different context could embarrass the team when the desired results are not obtained. The root cause or causes of hesitancy must be evaluated or determined. The best approach or combination of approaches for prompt resolution. I will end my presentation at this point. I thank you very sincerely for attention, and God bless.
Thank you very much, Ndayo Iwat. Thank you for this, for sharing this detailed and specific story. We're now going to turn to Deepa Pokharel, our guide on the side. She is a global expert on confidence in vaccines in general, and specifically COVID-19 vaccines. She's been listening. She's now listened to 9 stories, each one distinct, differences in context, differences in situations. The last 3, we're going to ask her to comment and share her reflections back. So those were the stories shared by Rukindo Margaret, Jimli Barua, and Ndayo Iwat. Deepa, over to you for your closing thoughts for this plenary, at least, on the last 3 stories, and more generally, what would you like to share with the practitioners, local and global practitioners who are here with us in the room?
Thank you so much, Reda, and thank you, colleagues, again for the last 3 batch of the stories. I'll just comment a few things on the last 3, and then I'll just like to make a general comment. So, of course, it resonates very well on what the global thinking has been. The health worker hesitancy has really been real. That's one of the priority population for us, and the colleague from Uganda really shared very real stories about what has really worked for them. As I said in the beginning, also health workers and hesitancy has to be taken really seriously, because they are not just communicators, they are also recipient of vaccine. So if they are hesitant, then it's going to be very difficult for others to communicate. So really hats off to you guys for really making sure that the health workers have the right information, and the social norm of whether somebody else is going to do it, I'll wait and see whether, certain other people are going to do it. Very much classically a behavior change communication thing that we see. So I think you've just done some excellent work, and it's very heartening to see from your approaches that it's gone from 15% to 65%. One of the approaches that has really worked across the countries is also testimonials from credible sources. So I think that it's really great to hear that. And from the UNICEF colleagues, presentation, what really came out very strongly is the partnership that we partners and government need to work together to make sure that things are really working for the communities with the different sets of communication strategy, including community engagement. One thing which is not often thought about is the adverse events following immunization, which means that are we ready to deal with any crisis in case something happens? Because if there is a negative influence from any of the rumors or misinformation, it has a ripple effect. So really glad to hear that. And then in the last one, what I really liked is that, the integrated approach is very, very important. This is exactly what we are seeing from other countries, listening to people, that it's very important that we look at what are the needs of the communities. What can we learn from the past polio campaigns? So I think I was really struck by how you said that the integrated service delivery mechanism was the way which helped you. And I think that in the closing thing, what I would like to say is that the priorities right now, what we are seeing post-Omicron is people have really reduced the risk perception. So we need to bring it up, that it's also about protecting others, not just themselves. That's one thing, but focusing on the priority population like health workers, elderly population, marginalized, people who are not able to access, like the people with disability. These are people who we need to consider when we are developing our strategies right from the beginning. Second thing is making sure that the communities are part of it, not just as beneficiaries, but in planning and co-creating, co-designing. Third thing is the misinformation has really made our lives very difficult because there's lots on social media. I think that and then let's see what has worked in one country, whether we can replicate in others, and to see whether, because every community can be very different. So with that, I would really like to think that, prioritization of the population, and also investing in resources as well as strategies for these populations are going to be very important. And let's tell our stories, just like you guys have been doing. That's going to be a really powerful testimonial for others to see it has worked here, maybe you can do it also. And you guys are doing such a wonderful job as our community. So thank you so much, Reda.
Thank you very much indeed, Deepa Pokharel. And all Teach to Reach participants who share story on COVID-19 vaccine demand are going to receive the invitation to join the global event organized by UNICEF and partners, including the Geneva Learning Foundation, that will take place on the 22nd and 23rd of June. We're now 1 minute away from the start of our next session, and all of our COVID-19 vaccine presenters, speakers, panelists are invited to stay on. We are going to move on now to the session that will be led by the Women Who Deliver Vaccines Collective. The topic is listening and learning from the experiences of women and men who are challenging gender barriers in immunization. Now, for those of you who've been networking, who are coming back into the room now, welcome back. And for those of you who want to go to network, there is right now, or starting now, a session in which you will be able to meet individually with colleagues and discuss what you are doing that is building confidence in COVID-19 vaccines. So again, very practical session looking at what you are doing in your daily work that is making a difference. So if you'd like to do that, just a reminder of how it works. This is where you need to go to the Hop-In platform, to the Teach to Reach conference, and click on the People tab and join the speed networking. This will click on join, and that's going to match you up with someone else in the conference. And we've shared the discussion guide that you can refer to in order to continue the dialogue that started in Plenary. Share your stories, compare notes, discover how people in other countries, colleagues in other locations in different situations are building confidence in COVID-19 vaccines. But for those of you who are staying here, a warm welcome to this session of Women Who Deliver Vaccines. As you can imagine, our mistress of ceremonies is one of the founders of this collective, 143 women from 38 countries who came together. And I would suggest perhaps to start with an explanation of who are the members of the collective. Charlotte, over to you.
Thank you very much, and warm welcome once again, everyone, to this special session organized by the Collective of Women Who Deliver Vaccines. 143 women from 38 countries who came together from all levels of the health system, who are involved in every stage of immunization service delivery, to share their challenges, to see how they can support one another, to ensure that those who need vaccines get them. So we are women from all levels. Many of them are here in the room, and you'll get to hear from them in a very short while. But remember, during Teach to Reach Connect 5 on the 4th of March 2022, we had an event to honor women who deliver vaccines in celebration of the International Women's Day. And afterwards, today we want to find out, since hearing from experiences on what people are doing to handle gender barriers to immunization, what have you been doing? And I'm glad to announce that so many men responded to our call, and they are doing so many things. So today we'll also get to hear from them. And I also want to recognize that before today's session, this one is actually the third event in a series of 3 that we organized with the Zero Dose Community of Practice around that works around strategic priority 3, that is coverage and equity. So the first 2 webinars were on social and structural barriers to immunization. This one today is purely experience sharing. Thank you, Reda, and over.
Thank you, Charlotte. And so we'll have 2 the session will be split into two parts. One is we'll be turning to members of the Women Who Deliver Vaccines Collective. And if you are a woman who works in vaccination, then you can consider yourself a member of the collective as is starting today if you have not already joined. There's, of course, the group of founders that Charlotte referred to. And we're looking to really your personal story as a woman working in immunization. You can see a number of questions here. I'll be pasting them into the chat in case you're on your phone or if it's difficult for any reason. And then the second half of the session will be looking to men and women. And as Charlotte said, we were impressed by the number of men who work in immunization who responded to express their solidarity, to share the invitation to this event, and to really want to express their willingness to contribute and help work hand in hand with women who deliver vaccines to make a difference. So Charlotte, let's start. Let's dive in. Who will be the first woman who delivers vaccines to share her story as a woman working in immunization?
Thank you very much, Reda. So I'm calling on the women who are in the room right now. If you are able to unmute yourself to respond to the questions on the screen in terms of what you have experienced as a woman who delivers vaccines. And just to say that I myself, I would like to speak a little bit because I am part of the collective of women who deliver vaccine. And I may not answer the questions directly as they are on the screen, but what I'd like to say is since the 4th of March, we have been getting more and more talk about around how women can get involved in immunization, how their place is indispensable if we are going to succeed and achieve immunization goals, especially when it comes to reaching the goals of IA 2030. And facing professional challenges as a woman, of course, yes, in my days of working in the immunization program in my country, I regularly attended meetings where I was the only woman, and we actually started a kind of talk in which we were saying, okay, we want to put forward promotion of gender equity and gender equality when people are convened for workshops and meetings. There should be some factors that ensure that at least 30 to 40% should be women and 60% the men. But I'm glad that more and more we are getting more women involved, not only on the front line, that is as vaccinators, as community health workers, but also at the level of decision making. But our cry as women who deliver vaccine is that we should get more voices, even women participating in our events, like is the case today. So right now, I'm going to turn towards.
And Charlotte, that's true. In a way, as mistress of ceremonies, in a way, it's unfair that you do not usually share your personal story. So I'm glad, or yes, I respond to the questions yourself. So I'm glad that you did here, as you are first and foremost an immunization professional. So we have the first woman who delivers vaccines, Sifiwe, who is who has unmuted. I'm going to put the questions back on screen. So Sifiwe, a warm welcome to you. Can you briefly introduce yourself, and then we'll go through the questions together.
Hello, how are you?
All right, wonderful, and wonderful to hear your voice. So you can see here, are you able to see the questions on your screen, and are you ready to? Yes. Okay, over to you then. The floor is yours.
All right, my name is Sifiwe Murepa. I'm from Zimbabwe. I work as a health promotion officer in Umzingwane district. But since the special event on the 4th of March, I was at the provincial office, so I was working actually covering the whole province of Matabeleland South. So during that time, actually, we had I had shared my challenge, or shared the situation that was there in one of the districts in my province. Actually, the issues that we're having is that we're having women that really wanted to get their children vaccinated, but because of the religion that they're into, the men or the leaders of the church did not allow them to get their children vaccinated. So actually, the breakthrough that we had is, after we had done a lot of advocacy meetings with the church leadership, they would put an excuse that it's the women that we're not coming for. Yet they will not allow us actually to get to have an audience with the women. So later we decided we opened a new clinic around the village that most of the objectors actually stay. And when the clinic opened, they actually enrolled some of the the women to work at the clinic. And those actually became our advocate for us because they knew they were from the same religion. So when they went back to their community and they started to relate how health services were good for them and everything, women started to come to the health facility, though nicodemously, because they are not allowed in their religion to get their children vaccinated. So, but we have had a breakthrough of women coming through secretly to get their children vaccinated, and even them accessing healthcare such as family planning services. So it has really been a breakthrough for us. Yes, we are still advocating with the church leaders, but we know secretly that there are other women that are already accessing healthcare, and that part is important for us. And looking at the current, we're facing a new an outbreak, measles outbreak, and as Mad South, we actually worried with, though, even though the outbreak is still very far from us in Manicaland, in the eastern highlands of Zimbabwe, but we are also preparing with giving them information how they can actually get their children vaccinated to prevent the measles reaching to their children. So it really has been a great experience when you see women that are now sort of empowered to actually go and look for services for themselves. So I would encourage other women in the immunization that, you know, when you do a one-on-one dialogues with these women, you actually realize they really want those services, but there are other barriers, maybe that can be social, that may be hindering them from coming for services. But when you really talk to them, you actually find out that they're really in need of these services. So we continue, though, dialoguing with the church leaders, but it's really been slow in that area. But we'll still continue so that at the end of the day, they don't come secretly. We hope we'll have that breakthrough soon. Yeah, thank you. I don't know if I answered most of the questions.
Thank you very much indeed, Sifiwe. Wonderful to hear your story. Now, with us in the room are those we call the guides on the side, and there are partners from the Zero Dose community of practice, as well as gender specialists from different international partners. We're going to introduce them in a little bit. They are Shubo Rashid Jalal Ruzbani, and I believe at least one other person supposed to join, but we'll go to Shubo after hearing several of the stories that are being shared, first by women who deliver vaccines, and then by women and men who are interested, who will share stories of overcoming gender barriers. Back to our mistress of ceremonies.
Thank you, Reda. I'd like to invite Boma Otobo. Boma, your hand is raised. You're one of the founding members of the Women Who Deliver Vaccines Collective. Over to you.
Hello, everyone, and thanks, Charlotte and Reda, for this wonderful opportunity, if I may call it so. My name is Boma Otobo, and I worked with the National Primary Healthcare Development Agency in Abuja at the national level, where we are strategically in charge of immunization, looking at women who deliver vaccines. I will count myself lucky because I never thought this opportunity would come, but the way I have found it, I have taken the bull by the horns, and I'm sure other women like me are also making great strides to ensure that at the end of the day, we get what we want. Yeah, so taking a look at the topic today, what has changed for me since March the 4th? Yes, I would say quite a lot. The experience of being with the Geneva Learning Foundation is something I cherish so much. And we all know the goals of the IA 2030, which is a vision of a world where everyone at every age fully benefits from vaccination for good health and well-being. So even looking at that goal, I take it as something personal to me. Vaccines are they are life-saving, and they are very effective, and they are not as costly as treating the disease, so to say. So when you look at this vision, it gives me a push And I'm so glad that I'm aligned with what the Geneva Learning Foundation is doing. Now, the second question is talking about the role of women in leading the 2013 IA movement towards its goals. Yes, we have seen the goal, and for me as a woman, I see myself as a goal-getter. I know that once you set a goal before me as a woman, just like I do even on the home front, I will not stop working until that goal is achieved. So you can see that women play a very vital role. Women are the caregivers, the primary caregivers. So for us to make up our minds that we want our children and others to benefit from immunization, then that's something good and great for the community as well. So women are leading, and women are definitely making their voices heard wherever they are. What can men do? Of course, men can encourage, in as much as also showing the way to go. So they can encourage, they can stand by us as women to ensure that whatever goals are set, we all achieve as one, so to say. Have you also had any professional challenges as a woman? I will say several. I have had several challenges. One that touches me most is when men or other people consider me as a weak link, so to say. And so you find that when we get to carry out a program and I'm deliberately sidelined because of my gender, I then take it on me that I need to prove myself that being a woman is not a curse. Instead, it is a plus. Because at the end of the day, I find even the men folks coming to tell me that I have done very well in keeping everybody together. It's like when you put cement in on the floor and you leave it and go and come back, it becomes hardened. That is the role of a woman in a team. The woman ensures that everyone achieves. So as much as possible, I have also tried to gain knowledge, because that's one thing that I would not want anyone to fault me about, telling me because I'm a woman, I do not know what I'm doing. No, I would rather want to teach them and train them, because I have gone ahead to learn and to make sure that I actually am getting more from what I'm being taught. Now, what will be my message to women? I want to encourage every one of us. We are not here by accident. I'm talking about the Geneva Learning Foundation. We have come here specifically to learn how women can lead. I like when men lead, but I like it better when women lead, because at the end of the day, the woman will not give up until she achieves success. So I want to wish everyone who is a woman here today, please take the bull by the horns wherever you are. Ensure that success is gotten. I want to say this again. I like working with the traditional institutions. Wherever I go, I try to identify who these gatekeepers are, and I make my presence known to them. And I ensure that at the end of the day, if I have issues, challenges, I always run to them. And once they speak, everybody goes in, to do what they've asked that we should do. So I like to leave it at this point and to wish everyone here success in what we do. Over. Thank you.
That inspiring and motivating experience that has been shared. Right now, we'll listen to one more before we turn to the guides on the side, because I have Lucy Kanja that has been waiting for quite a while.
Yeah, greetings from Kenya. I'm Lucy Kanja, Vaccines and Immunization Consultant, working with UNICEF and currently supporting Ministry of Health, National Vaccines and Immunization Program. I've been a member of Geneva Learning Foundation for quite a while, and every time I join in, I learn new information, and therefore a great platform for us to learn. Now, on the questions of the day, what has changed since I joined the special event on March, and what am I doing differently? Number one, after learning on the global strategy on leaving no one behind. It was like an eye-opener to me, because now you realize we are not having the only infancy vaccination services. We also have now the adult, and even with COVID-19, new challenges have come on board. And therefore, now I look at immunization program differently. Then question number 2, what is the role of women in leading immunization agenda 2030 toward its goal? Looking at the strength of women and their concern for the families, to me is a force to reckon with. And particularly when I look at the priority framework of action of IO 2030, Immunization Agenda 2030, I'm in love with priority number 1 about primary health care and universal coverage. Also number 3 on coverage and equity and outbreaks and emergencies. And why did I choose those 3? And also I'm in supply chain and sustainability. When you look at especially when there is outbreak and emergencies, the women and children are the most vulnerable populations that are affected whenever there are those challenges. And when we have voices of women coming in to support the programs, make sure that their voice is heard. Then on question number 2, who are the individuals involved? What gender are they identify with? Number 1, when we involve women in health strengthening, you look at all the components of health system strengthening, from leadership and governance, health financing, healthcare workforce, health infrastructure and service delivery, health commodities and vaccines, health information system. When we have those voices in all those components, you find we are able to achieve more, and because we are able also to reach to the last mile. Then what is the role? Or your responsibility in this situation? I was remembering one community that we visited, and we went to give vaccination because we realized they had so many cases of 0 doses, and therefore we felt that most children were missed out. And when we visited that community, we realized that the women were not allowed to give consent for vaccination, and we had to wait up to the weekend when the men are in the community so that they can give permission for those vaccination to continue. And I learned from the engagement that we had with the community, and they allowed the teams to be going there. There was an opening of having door-to-door every second week of the month. And for me, that was a game changer, that somebody was able to put a face on the importance of vaccination, even to a community that had it was a group of people that had refused vaccination. And what are the barriers that we found? The barrier was like now how it had to take us a lot of time to convince the gatekeepers that they can allow their women also to decide on the vaccination services. And how did it end? It was a win-win, because currently the services are ongoing door to door, but over the weekend. So we had to go out of our way, instead of the way people were used to just going Monday to Friday. Now they are able to go out of their way and go over the weekend to make sure that no child is left behind. And what was there anything that surprised us? Yes, because that community is in the city, and we did not expect to have such barriers. Even when people are in the city, we expected that to be in the rural area. But we are glad that now they have accepted, and therefore children are vaccinated. Over.
Thank you very much indeed, Lucy Kanja. The time has come, Charlotte, I believe, to turn to our guides on the side. So we have two that are going to introduce themselves when they speak. So Aftab Kawaja and Shubo Rashid Jalal Ruzbani. We're going to start with Aftab and then Shubo. Please, as we ask of all participants in these very short sessions, please be concise, get to the point, focus on really responding in terms of the support that you're able to provide to in response to what you heard. We'll also, if time allows, we'll turn to Deepa Pokharel, who's kindly offered to also share her feedback and insights. So over to you. Let's start with Aftab.
Thank you so much, colleagues. Good morning, good afternoon. It's Dr. Aftab. I'm working with the immunization team based in UNICEF, country of West Islamabad. So coming back to the point, I heard my last two colleagues, Momi and Lucy. And due to connectivity problems, I was not able to join from the start of the session. So I really like these two talks by these colleagues. So as mentioned by Momi, I think the key point was, which I really like, that as a female, we need to follow the results, and we need to be leader at every point, at every point in our life. When women will take the leadership role, they will take us to a kind of success, not only in their professional lives, but in every aspect of our life. Whether being a caregiver at home, at workplace, wherever they are. So that's a kind of critical point. I think it's a kind of basic principle which we need to follow, that as a man, we need to give this role to the our female colleagues at every point, at every aspect in life. And this leadership role, when it's taken by our female colleagues, that will have a huge impact in each and every aspect of the life. Secondly, I also really like this discussion by Lucy. I mean, the key point she made, I mean, that's a kind of real bottleneck, that the decision-making part is not with female. The decision-making part, it's with male at home, who is not at home, who is not taking the responsibility of caregiver at home to kids. I mean, we also observed it's a kind of, as a common practice, that the decision making is with male, and whenever our teams they are visiting to the community, mother or female caregiver at home, they don't have the power to take the decision whether they need to, whether they can have their child vaccinated or not. So the impact is not only on the female child. This lack of having a decision making authority with our female caregivers, it's also impact the male child at home. She's not able to decide whether she need to get their male and female child vaccinated or not. So which is definitely contributing to our zero dose children and zero dose communities. So I mean, if I summarize these two things, number one, we need to advocate to give the leadership role to our female caregivers at all levels, and then the decision making. And this will definitely help to improve the immunization coverage, reduce zero dose children and zero dose communities, and help us to achieve the IA Agenda 2030. So I will stop here and handing over back to my colleagues.
Thank you, Aftab Kawaja. Over to Shubo Rashid Jalal Ruzbani.
Yeah, good morning, good afternoon, colleagues. I'm really pleased to be with you today. I hope you can hear me.
Loud and clear.
Okay, good. So I really want to thank, I'm the Senior Gender Advisor in UNICEF Headquarters, and I'm really pleased to hear the stories and join this session very interesting and very informative indeed. I want to thank Charlotte, Safeway, Lucy, and Boma for sharing their stories and the inspiring messages that they have actually shared with us. I would like to give you what I heard. I heard we can achieve more by giving the voice of the women and girls in the field, listening to them. I heard men can be effective, men can be obstructive, but men can also achieve more if we engage them. I heard female health workers have a great role in the IA 2030 agenda as implementers, as leaders, as actually the agents of success for such agenda. And we heard how we shouldn't actually look into the female health worker as a weak link, but as an empowered link. And I also heard that let's also look into the gatekeepers and see how we can achieve more. So we can achieve more through this. This is what I got from the different stories that we have heard. And I would like to add also to that is, when you have that resistance by the religious leaders, let's learn from each other. There are some success stories in other countries that we can build on. For example, in Egypt, there was this book that came out from the Coptic Church, advancing the rights of children, and of course, it was jointly with the Al-Azhar Muslim community, where they are advocating for the rights, including the rights of health. How can we use those as a push factor to those resistant in that particular community that you were referring to, Safeway, in Zimbabwe? So learning from others, sharing the experience, and I think the empowerment that comes from this kind of connection amongst the countries, the women who deliver vaccine, the professionals in this field, I think this kind of gathering is also an empowerment where you can pose your questions. I have such a problem. How can you help us in doing that? Well, women in leadership, generally, globally, like 70% of health workforce is female, but not as that significant in leadership position. And this is really important. I want to give you an example. I was in Yemen developing communication materials for cholera outbreak. And all those who are engaged in developing the materials, and the materials speak, dear mother, dear lady, dear sister, all the materials having addressed the need for the woman, but all those who are involved in developing those materials are actually men. And this is a concern. I have raised it with the ministry, and the ministry acknowledged that. How can you design a message targeting women by only doing it from behind the desk? You need to go down, you need to listen to them, you need to know what are their concerns. Like Safeway was saying, no woman does not want health for their babies. They want to vaccinate. Once they understand the value of vaccine, they run to vaccinate their children. But it is the choice and the empowerment. So if we are not able to give that positioning, that empowerment for the women at household level, given all the challenges, the domestic work, the fathers do not allow, the cost of taking the child to vaccination, making them more engaged, give us an opportunity to achieve more. I'll stop here. Thank you.
Thank you, Shubo Rashid, Jalal Ruzbani. Charlotte, it sounds to me like you may have a new member of the Women Who Deliver Vaccines Collective. Are you going to invite Shubo to join?
Definitely, Reda. Remember, we say we are women from everywhere, from every level of the health system. And if we need global voices, then Shubo is welcome to join us and to be our global voice.
All right.
My pleasure to join this. I will be humbled to be joining this a great initiative.
Thank you, Shubo. And we do have a third guide on the side. It'd be a loss for our plenary if we did not hear from Deepa Pokharel. Deepa,
Thank you, Reda.
Yes, please. Would love to hear your thoughts, reflections after the 3 stories, and then your colleagues who've already commented and responded.
Thank you. Thank you so much, Reda. So just on a quick introduction, I think this might be a different audience. My name is Deepa Pokharel, and I'm the Senior Advisor for Social and Behavior Change, but also the team lead for vaccine demand at the global level with UNICEF headquarters. So a lot of these things, what I think the colleagues have commented on the stories, great stories to hear from colleagues, but a couple of things which really sprung to me. One is the empowerment. At what level are we? Are we having women on the table as equal partners when we are developing, whether it's a government level plan or micro plans at the community level? We really need to have equal footing at the table so that real issues come. But we're not saying that gender is just about women. Of course, there has to be an equal voice given to both men and women. The second thing is rather as what can we do to address some of the things that we are seeing in immunization related to gender. There are many practical issues, timing not being very convenient for women. Are we doing something extra to reach to the women, elderly women in the COVID, for example? There have been many experiences of people feeling not comfortable coming for the girls not wanting the HPV vaccine to TT vaccine. So these are just real issues, and the strategies when we develop, as Shubha was saying, how can we develop something without engaging the girls and women themselves? That's very important. But I would also like to say that men have to be engaged, not just as supporting, as decision makers, but also to make sure they are taking care of the children's need in the immunization. It's not just the women's role to get the children vaccinated. It's equally the responsibility of the father, the grandfather. So I think we'll have to look at it in a different way of the women at different levels, all kinds of women that we've heard from, at different levels, from community health workers. We all know that majority of the community health workers are really female, and how do we empower them so they are equipped with not just information but also the peer-to-peer support, the things that they may need in terms of having a proper HR in place. How do you advocate that there needs to be more female in the system? I think we'll have to look at it very holistically, and all these stories from the women are very empowering, starting with our own very Charlotte. So thank you so much.
Thank you very much, Deepa. All right, back to our Mistress of Ceremonies. So this time we're going to go to the second half of this plenary. Think of a recent experience when you encountered a gender-related barrier or concern when providing immunization services in your work, and you were able to do something about it. So you're going to tell us again, get very specific, not generalities or your opinion about these issues, but something that actually happened that you were directly involved in. We want to hear your story. Over to you, Charlotte, to tell us who will be our first speaker for this segment.
Thank you very much, Reda, and I'm encouraging our men, our brothers who have stories around resolving gender barriers to immunization. You have the opportunity now to raise your hand, but I'm going to turn towards Dr. Joy Ataudi, whose mic is already open. Joy Ataudi, over to you. Share your story with us.
Thank you very much, Charlotte. Thank you, Reda. Thank you, everyone. Actually, I had an experience during one of our activities. Sorry, my name is Joy Ataudi. I'm a volunteer supervisor, immunization supervisor, and I work in Nigeria. And I'm opportune to work even at the national level, but I get sent to supervise immunization activities even at the community levels too. So one time during an activity, we were immunizing children, and we got to this particular house where the young mother, who was about 19 years old, insisted that she would not give her children release her children to be immunized. And that was simply because her husband had not permitted her husband had not given her the permission to release her children for immunization. So and her husband was not at home at the time for me to ask to get permission. So I was able to educate her, and I asked her, and she said, look, do not waste your time, because I will not release these children until my husband has agreed. she herself said that she knew the importance of the immunization and that she was willing, but until her husband gives the go ahead, she will not do that. So I took the time to trace her husband, and we were able finally to trace her husband, and I got him. After much begging, cajoling, explaining and all, we got him to grant the permission, not just for that particular round of immunizations, but for subsequent ones. And what was really important, what was really a big win for me, was being able to enlist him as one of the people to help even convince other men in the community to give such express permissions to their wives, even when they were not at home. Thank you. That's my story. So the other question is about what happened. The main, okay, I had said what happened, and the people involved.
Yeah,
Hello,
Joy,
can you hear me?
I think you covered it all. I'm looking to Charlotte.
Yeah.
Thank you.
Thank you so much.
If you could just tell us, is there anything that surprised you?
Yeah, my surprise was that even though the woman, I expected that, well, she understood the importance of immunization and she was willing. But the fact that she said that even if she herself got sick, that she would not go to seek help until her husband was able to take her. So that's really surprised me, and that got us thinking as to what to do to begin to look at the root cause of such things and see how we can tackle that. Thank you
very much. Thank you so much, John. I would like to, Emmanuel Katubwa, your mic is already open. So you are the first man to share your experience in this particular plenary. Please go ahead and do not forget to introduce yourself.
Yeah, thank you, Reda. Thank you, Charlotte. Yeah, and Reda and every other person. Good afternoon, good morning, good evening. I am Katubwa Emmanuel. I work with the WHO in Nigeria, Yobe State. And I am an immunization expert, now reassigned to surveillance activities in the country. The situation I'm going to describe now happened while I was in my former station in Adamawa State of Nigeria. I actually went to a health facility to do some routine immunization, supportive supervision. And yeah, fair enough, the health worker there was a female, is a female, and at the end of all the, the filling of the checklist, on the ODK, you go out to carry out this community survey, just to see the status of immunization in that community where the health facility is located. And I went out and I started my survey and came to this house, where I saw 2 eligible children on the one children. Actually, they were just about a month old. They were twins. And I looked at the immunization cards and I saw that these are 0-dose children. They didn't have immunization cards. And I asked the woman, what happened that your children are not immunized? And well, she said, well, she didn't give birth to them here. She gave birth to them in another place, and they came here to, to where the parents are. I said, okay, but in this area, there is a facility and they offer immunization services. And she said, well, she cannot go out until 40 days after the birth of these children. Wow, that was actually the gender-related barrier. And the good thing is that, of course, she believed in immunization, but because of this barrier, okay, she just took everything for granted and didn't really bother, asking where such services could be gotten. Fair enough, there was her younger sister in the house who was, old enough, to carry these children to the health facility. So I asked, I said, now, this lady by your side, who is she? She said, she's my sister. I said, good. If you can't go out within 40 days of the birth of these children, your sister, okay, could carry these children to the health facility where they could be immunized. She said, oh, that's true. I said, fine, if there's no problem, why not? Let her come along. We will take the children to the health facility for vaccination. Good enough, there is this daily immunization going on in some health facilities in Nigeria. So that was how we took those children to the facility, and they were immunized. And I told the female health worker, I said, look, you don't seem to have any problem in this community. It's like a lot of your clients are very compliant, but look at even within, this high acceptance level, we're getting we're getting some zero-dose children in your settlement. That means you need to do a lot more to try and capture this kind of children in your community. And it turned out very well that, those children got immunized even without the woman coming out. Nothing much surprised me. It's just that the environment was a very compliant community. She just happened to be found in that community, and good enough during this community survey, we found her out, and we were able to immunize her. Another thing I'll also advise is that women should always talk to their fellow women in communities, if the awareness is high. I guess one of the women, one of her neighbors in that area should have, ab initio, encourage her to, or encourage these children to be immunized, just like we did. Thank you, and over, Charlotte.
Okay, thank you so much, Emmanuel Katugwa, for sharing this experience. I would like now to turn to, we have so many hands raised and so little time. So I'd like to turn directly towards Carolina Kosile. Carolina, are you able to unmute yourself?
Yes, please.
Please,
go ahead. Good day, everyone. I'm very happy to be on this call. My name is Caroline Nakoshile, Communication for Development Specialist. I worked for UNICEF Nigeria at a regional level in Lagos and Accra office in Nigeria. And basically the questions today, the first question talks about a situation that happened that is mainly gender related. Well, it was during an immunization session in Jigawa State, house to house. And we got to a house with a child, a zero-dose baby, and it was on supervision and it was reported. So we saw the issue as a gender barrier, decision making, and the norms and culture related. But the mother of the baby said she had to wait for her husband, just like a colleague had said before. So we waited for her husband to come back, but he refused. But we had to also talk to the gatekeeper of that community. He was the one who now convinced the man, and the child was vaccinated. Ordinarily, the woman of the house does not have the power to make decisions on her own on the son's health because of different rules that are dictated by the society, gender norms and values. So there was this also the issue of lack of education, because if the woman was really educated and informed about the survival and health of her baby, I'm sure she would have found a way to say, okay, maybe the baby should be immunized, or talk to the husband, or go to the gatekeeper in the community who we saw that really supported immunization. So what happened that day was really gender related, and it's a barrier. And the issue in that community is the one that speaks to power relations, whereby the male, the husband, wields more power due to tradition, due to culture and norms. So the woman lacks decision-making autonomy. She cannot make any decision without the husband. And the woman also is illiterate. She doesn't work. Even if she wants to take the child to the clinic, she doesn't have the money for transportation. So here comes inequity and inequality with the man. So who were the individuals involved, and what gender do they identify with? The individual involved are the young mother whose power in society as a woman was little because of her gender, and a man, her husband, who is a decision maker. And the last person involved was the innocent child, that boy, the zero those boys, who was in the middle of this decision making between the man and the woman. And then our role that time was facilitating as government partner, as development partner, and as a supervisor during the immunization days. And then our role was also to make sure that every eligible child was immunized in that place, and despite the power situation on the ground. Then the fifth question talks about what did we do? Well, we spoke to the person that had the power of decision making, who was the father of the child, and also the gatekeeper of the community, who we were lucky to be on our side. So he persuaded the father, and then also made sure that all the children in that community henceforth were actually vaccinated. It went out well. It turned out very well because the children were now immunized. Then was there anything that actually surprised me? Not really, because gender inequity in health occurs between men and women in some parts of the world, not just only Nigeria. Men are supposed to be the decision makers, and this poses barriers for women and girls to access health information, and they can't make decisions, and they also have limited access to finances. Also, education is a problem because they have literacy level that's very low. So basically, the woman, if she was educated, she would have known that it's good for her to educate her child. Thank you very much, Reda and Charlotte and all our facilitators. I'm very happy to be on this call.
Thank you very much
Thank
indeed.
you very much.
Now the time is cruel because we have 5 minutes for our final speaker, and then we will have 90 seconds each for for two of our guides on the side, Aftab Kawaja and Shubo Rashid Jalal Ruzbani, to share their final thoughts before we close this plenary. Charlotte, over to you.
I'd like to invite Matthew Joker Matthew from South Sudan. Are you able to unmute yourself?
Thank you very much for this opportunity. I'm called Matthew Joker. I'm from South Sudan. I work for WHO. I started work as EPI from 2000 until now. The situation that I went through was during the polio campaigns. There are a lot of situations that we went through, but one of the situations that actually I was very impressed and I was really happy was one of the during one of the campaign, one village, the whole village refused to take polio vaccines. So we mobilized ourselves at the state level with all the stakeholders, including the council director, and we invited the chiefs, the women group, and the youth group, and all the members to come for the meeting. So during the meeting, the whole mothers refused that they are the people who suffered with their children and they cannot actually give their children for immunization. They don't want, because this polio is a vaccine that is going to stop them from producing. So they don't want they don't want their children to be vaccinated. So they continued, because I don't know the dialects. So I was there was a time that I was given time to speak. The first question that I ask you now, you have the right because it's your child, but I have a question. Why do you allow yourself to conceive and you stay with a child in your womb for 9 months, suffering with your child, until you deliver the child, and now you abandon your child to the disease that can be prevented? That's number one question. Number two question, I ask the chief, if suppose we came with 10 children crippled and 1 child that is well immunized and healthy. Which of the 2 you will take? All of them say they will take the 1 child. I say, why? The 10 are more, and this one is only 1. Why are you wanting to take only 1 child? They say, because this is healthy now. I say, okay, if that is the reason, now you have to immunize your children so that your children may become healthy like this 1 child that all of you agree to take. So from that meeting, the chief, the women group, and the youth group leaders, they all agree, okay, now if that is the situation, from today, they wanted all the children in that village to be immunized. And the chief has to give orders that from tomorrow, let the vaccine be brought, and I have to be there so that I have to witness that all the children are immunized in that village. And that was the first time that the village was fully vaccinated. The children, all children were vaccinated by that day. And that was when I became very happy. And in immunization, we have to make sure that we involve all the stakeholders. For example, the chiefs, the women group, the youth group, and other stakeholders, so that we can give them the real message about the immunization and about the disease itself, so that they can understand. After understanding, they are the one to take decision, because they own their children, but we have to tell them the difference, the burden of the disease, and the benefit of taking vaccines. I think I will not take time. That's what I have. Thank you so much, and thank you for giving me this opportunity.
Thank you very much indeed. We're now going to give, and this feels really unfair. We're going to give 90 seconds to Aftab and Shubo, 90 seconds each to share their final parting thoughts. And I hope that this is only a stepping stone to the kind of dialogue between global and local partners, between global and local practitioners that we'll be able to imagine and then make happen together. We started with Aftab last time, so let's start with Shubo and then Aftab.
Yeah, thank you very much, Reda, and thank you very much, colleagues Matthew, Emmanuel, Jaya, and So, thank you very much for sharing those experiences. 2 things that came out for me. One is the importance of gender analysis, because it is the root causes. We are sitting behind the desk and we're planning our immunization team, but planning, and we do wonderful outreach. But then if we do not understand what is it exactly the basic barrier at the household level, we will not be able to solve the problem. So gender analysis is a key message that I want to pass through the session. And it is really important in the planning stage, in the implementation stage, and in the monitoring stage. That's number 1. Second, because you heard all the stories, her husband doesn't accept, the religious don't accept, the cultural norm is that. So we need to know those to be able to say, yes, our vaccination will succeed or not. The second thing is the investment in local solutions. So the example from engaging one father that has actually led to engaging other fathers in the community. It's an investment, a cost-effective investment. The engagement of women groups in the example that Matthew shared with us is a simple way of addressing a big issue. The example that Dr. Emmanuel has shared with us is, look at that, very simple answer, very simple solution. Let the sister take the child. So he did not challenge the norms. He actually addressed them and accommodated them. So simple solutions, investment in local solution are really important aspect that we need. These are the things I heard. I want to add one important aspect, which from my side, the capacity of health worker in convincing, the communication skills of the health workers in convincing. How do you convince a father that is rejecting because of religious leaders? How do you convince a father who is rejecting because he read this article on the internet that immunization causes autism? How can you convince that communication skills, convincing strategies is really an important empowerment component that I would add to every training component for health workers. Thank you.
All right, thank you very much, Shubo Rashid Jalal Ruzbani. A final word from Aftab, and it'll have to be much shorter than your colleagues.
Stop it.
Thank you so much, colleagues, and thank you so much, Manuel, Carolina, and Matthews. When I was listening, it seems that I'm directly interacting with at household level with mother. It's not that I'm listening, colleagues, and thank you so much for really sharing your experience from the ground. So, in summary, I will bring another aspect of our immunization service delivery, and it's the immunization system, resilient immunization system, system strengthening aspect. I mean, colleagues have witnessed and shared the bottlenecks identified at household level, which relates both to the supply side of the system and demand side of the system, by caregivers and by our supply side. So how now these bottlenecks have been identified? Our colleagues have taken a kind of exceptional corrective measures on ground. But what I was asking myself, so whether we have that resilient immunization system where gender sensitive, all the gender sensitive strategies are being implemented to have this a kind of long-term solution, long-term local solution, as Shabo mentioned, of all these bottlenecks. So what I will suggest that we need to have a kind of we need to establish those community platforms at community level where we need to empower the communities to access these services more effectively. A second is the missed opportunity. I mean, we need to consider those missed opportunities and like these deliveries at maternity home, vaccination at maternity home, outreaches, and empower our female caregivers and workers to address these issues.
Thank you, Aftab Kawaja. Yes, thank you very much. We have a follow-up. The next plenary is focused on neglected needs of women's health. It's starting in less than 1 minute. We do keep to Swiss punctuality when it comes to these sessions. We have both panelists and guests in the room. You, of course, our guides on the side are welcome indeed to stay on here. So let's kick off now our third and final plenary. Warm welcome to you from Geneva, Switzerland, and from Eboloa, Cameroon. Charlotte, how are you doing? This is our final plenary focused for the first time on the topic at Teach to Reach outside of the field of immunization, neglected needs of women's health, and specifically female genital schistosomiasis. We're going to have to be sharing experience. How are you feeling about this final session today?
I'm feeling really great, Reda, and I think it's the fact that it's back to back with the session, the plenary that just ended on gender barriers to immunization, and this is really a neglected, I call it the most neglected of neglected tropical diseases, female genital schistosomiasis, and for those who are involved in immunization, I really want to encourage them to stay back in the room and listen, to familiarize themselves first and foremost with this disease that affects over 56 million women and girls in sub-Saharan Africa, and also get to listen to what scholars that took part in the FGS, the female genital schistosomiasis workshop, are doing on the field to fight against this disease. Thank you, Reda. Over.
Thank you. And just we know that, so there are 3 parallel sessions again. So I'm going to run through these sessions before we really kick off. And so you can stay right where you are listening to this plenary, whether you're on YouTube, Twitter, Facebook, or in the Teach to Reach Connect hop-in space, or here with us in our Zoom studio. Now, the alternative, you have 2 other options. So you need to make a decision. And some people go back and forth between sessions. You can do that. But I would encourage you to just make a choice and stick with it. There's a networking session to discuss how I am you are challenging gender barriers in, it's actually in healthcare more generally. And then we have a session which will take place in the Teach to Reach space. I will show you where that is. You click on sessions and then you go down here to where you see the banner for the movement, and that is where you will join our Insights unit to discuss how you can become a contributor, co-author, editor for the Immunization Agenda 2030 movement. So those are your options. But if you stay here, then that means you are here, you're going to discuss, share experience, and learn about female genital schistosomiasis. As with our other plenaries, we're privileged to have some of the leading global experts on this topic in the room with us. And today they are our guides on the side. You will be hearing from them and they'll be introducing themselves as we progress, as we listen to the experiences being shared. But first, I must tell you the story of how the Geneva Learning Foundation came to be involved in a topic that we knew nothing about. And in May and June 2021, over 300 healthcare professionals in sub-Saharan Africa participated in the Fast Package Workshop, a coalition of organizations and experts committed, dedicated to tackling female genital schistosomiasis. And they asked us if we could partner to actually work together, bringing the Geneva Learning Foundation's unique package of interventions to bear on this particular issue. Working together, these global experts produced some remarkably useful resources, such as the frequently asked questions, which we'll be sharing with all Teach to Reach participants after this session. And then working together, these health professionals, hand in hand with the global experts, developed 213 action plans for local solutions to tackle FGS, each in their contexts. And so we asked participants to describe their key challenge, to set a goal, to identify actions. And we had 213 scholars who developed action plans. Now, for those of you who are immunization scholars, you are familiar with this process, and we hope you'll appreciate what I'm going to say next. Is that we brought the Impact Accelerator, developed originally with over 600 immunization professionals. And we said, well, let's see if this approach in which you develop an action plan, but then you're challenged to take action, if that will work, how that will work for people tackling a different kind of challenge. And the Impact Accelerator is really a human knowledge network, 4 pillars around making a pledge, but also making a commitment to shared peer accountability, to sharing experience, and ultimately to mobilization to action. So I'm going to ask Charlotte Mbou, my mistress of ceremonies, co-MC for today, to read the scholar pledge. And this is the FGS scholars. If you're an immunization scholar, you know the immunization pledge. Here is the one for female genital schistosomiasis.
Reda, it's always a pleasure for me. I am committed to work for a world where everyone, everywhere is protected from neglected tropical diseases, and especially female genital schistosomiasis. As a scholar, I hereby solemnly pledge to work with others to transform projects led by scholars into action and results that will improve health outcomes. Share my success as well as my challenges by reporting on a regular basis on my progress towards implementation and supporting fellow scholars in doing the same, while upholding the highest standard of integrity and behavior. I make this pledge to contribute to the global goals for the health of women, men, girls, and boys in my country and everywhere. Thank you.
This is how we started with working with the FAST package, with Bridges to Development, with Bruyère, who are here in the room today as our guides on the side. And we're going to hear an update since that Impact Accelerator for FGS. What have local practitioners gone ahead and done with what they shared, and how have they mobilized over time? So Charlotte, I know there are FGS practitioners in the room, and I'm now turning to you to identify our first speaker who will share what they have done since participating in the Impact Accelerator, in which they had developed a plan for action around tackling FGS. What have they done since?
Yes, Reda, I'm inviting Rabiu Ibrahim. Rabiu, if you are able to unmute yourself, over to you.
Hello, everyone. Hello, everyone.
Yeah,
Hello, Rabiu
Yes,
Ibrahim. So please tell us, is the story you want to share, first, before you introduce yourself, do you want to share a success story, a lesson learned, or a challenge?
Yeah, good morning, good afternoon. I am Dr. Ibrahim Rabiu, a fellow of West Africa College of Physicians, a lecturer with Community Medicine Department, Gombe State University, and a honorary consultant to Federal Teaching Hospital. Yes, I'm one of the FGS scholars that attended the online training by Geneva Foundation on May and then October 2021. In this way, we were asked to develop action plan. We have other scholars from Nigeria, and I think for us coming together and form a network will actually help us to achieve our action plan. So we actually form ourselves into a network, and then we were communicating through WhatsApp group, and we were able to invite others in Nigeria to join us, and since then we have been engaging. March this year, we transformed the network into an NGO, and then registered with CEST in Nigeria. It was launched on the 30th of March 2021, and also we have a website which we unveiled, and also we did a documentary. We started just 11 of us, and as I'm speaking to you now, we have over 300 members across Nigeria. And then we have CISO in Nigeria, we have branches there, and then we have state branches too. Our intention is to take it to local government branches, but at this level we are at state branches, and we are able to organize training across tertiary institutions across this 6 geopolitical zone. We did one in a Federal Medical Center at Bekuta. We did one in State Special Hospital Bauchi. We did one in Lokoja, Kogi State. We did one in Delta State and also in Kano. And then we have trained over 200 health workers about awareness in FGS. As I'm talking to you now, we are carrying out case searching about FGS in 2 states, Gombe State and Bauchi State. We are in a collaboration with the Federal Ministry of Health, Nigeria, and some other sister agencies. With the assistance from Bridge Development, we are able to launch the NGO March, and then from the launch, we are able to secure 2 colposcopies. We send one to Federal Medical Center at Bekuta, and also we also send one to Federal Medical Center in Lokoja. And from the launch too, we were able to secure a router. This is a form of internet access to help the state activities in carry out awareness about FGS. As I said, we are in contact with some NGOs within the country and also outside the country. Dr. Garba from WHO was able to assist us with IC material, which were distributed across health facility in Nigeria about FGS. And as I said, we are on the track to carry out case searching in 2 states. We are at the stage of colposcopy examination of those that are positive to female genital schistosomiasis. Our NGO's name is called Female Genital Schistosomiasis Society of Nigeria. As I said, we have a website which you can access. Probably I'll share it at the chat box. You can access our activity, and also I also have a website, an email which you can communicate to us.
Thank you, Dr. Rabiu Ibrahim. I do have a question for you. Did you know? So Julie Jacobson has already kindly shared the link to the FGS Society in Nigeria. Did you know your colleagues before joining the fully digital workshop that took place under the auspices of the FAST package? Did you know them before, or did you meet during the workshop?
Yeah, actually, we didn't know each other. at the first training meeting, I was able to contact and get their address and their phone numbers. Through their phone numbers, people like Emmanuel Musa from Kaduna, Dr. Hamidat from Ogun State, Dr. Adeboshara from East. I was able to take their phone number during the first their first training in May 2021, and then I was able to be in contact with them. And then when we came back for the October training, we now form a network that later transformed into an NGO. Before the information, I don't know anyone, and then we live in a different state, and they are far apart. I'm in the northeast of the state. Hamida is in the southwest Ogun State, and Sonia also in the southwest. I don't know any one of them.
Okay.
We come together through the training at the level competition.
Wonderful. So this is remarkable that this happened through a fully digital initiative and not a hotel-based conference. We'll come back to that with our guides on the side, where we'll ask them to respond after having heard several of the stories. I know that Charlotte has several speakers already lined up. Charlotte, over to you.
Thank you so much, Reda, and thank you, Rabiu. I'm inviting Mary Ashinyo from Ghana. Mary, are you able to unmute yourself? Okay,
yes,
over to you.
Thank you very much. Good afternoon from Ghana. So my name is Mary, and I am a public health physician. I work for the Ghana Health Service as Deputy Director of the Institutional Care Division, responsible for quality assurance. So I head the Quality Assurance Department of the Ghana Health Service. The department also hosts the National WASH and the IPC program. So I got the opportunity to participate in the online program on female genital schistosomiasis. And following this training, I got a call from the National Neglected Tropical Disease Program to collaborate to be able to develop some training materials for schistosomiasis control. And we decided to include a component on WASH and IPC. So WASH is water, sanitation, and hygiene, and IPC is infection prevention and control. So what happened was that before this invitation to collaborate, there were so many teaching materials on schistosomiasis, but they did not include any content on WASH and IPC. So what we did was to hold workshops with the National Neglected Tropical Disease Control Program, where we developed training materials, and then we conducted training in some selected districts that were on this program or on this intervention funded by World Vision Ghana. So after this training, the content of the training actually includes how to improve all the domains of WASH, including water, sanitation, hygiene, waste management, and then infection prevention and control. Why this is important is because if we focus, I realize that if we focus on just clinical treatment of these persons, they can go back to the communities, have contact with very bad water sources, have contact with the vector, and still be able to come up with another infection of female genital schistosomiasis. That means that the preventive component is very, very important. And so through this program, we were able to create awareness about the transmission cycle that results in people getting schistosomiasis and how they can also have the appropriate water, sanitation, and hygiene practices that would help them to prevent schistosomiasis. And I would say this has helped me because I have contributed to the preventive component of female genital schistosomiasis, and we have also built capacity of a group of clinical champions, healthcare workers who would also go into the communities as community health workers to also educate the surrounding communities about how to interact with their water bodies and how to protect themselves against schistosomiasis. Well, what surprised me was that some of these communities that I had visited about 20 years ago, distributing the magic drug are still, having high cases of schistosomiasis, which means that we really need a holistic approach to control of these diseases. And I'm happy that the Ghana Neglected Tropical Disease Control Program is making very good strides to achieve this aim. So I would say that this has been my initial contribution, and I look forward to doing more of these. Thank you so very much.
Charlotte, we're going to hear, I believe, a third speaker before going to our guides on the side, who will then share their reflections, their comments, their feedback on the stories that we've heard so far.
Yes, Reda, I'm inviting Victoria Gamba, who is already unmuted. Victoria, over to you, and please start by introducing yourself. Victoria?
This may be a case of microphone unmuted, but with no audio.
Yeah, so then I would like to turn towards the...
Oh, there she is,
yeah.
Victoria.
Oh, great.
Yes, hi. Sorry, a bit of a network challenge, but my name is Victoria Gamba from Kenya. I am an obstetrician and gynecologist, sexual reproductive health rights specialist, gender advocate, and most importantly, I am a trainer on FGS. And especially on matters of diagnosis, treatment, and also currently we're working very hard to integrate FGS into the various strategies that we have. So my story is more of a successful story, but with a lot of need on more integratory approach to FGS. So why am I saying this? So my FGS story began a while back. And one of the things that was a success that we managed to, together with the Ministry of Health and LVCT, we managed to actually get to the remote parts of our country, that is in Homa Bay. And we wrote a proposal, we did a formative study that we were able to actually tell the community about FGS, which they were very surprised that it is there. However, on reaching there, the two photos that I took that really haunt me until now, that's why I'm really so keen to continue with this journey. It was the photo one was just showing, the Lake Victoria in all its glamour and the vastness of it. But then now on the left side, you could see women. It was early in the morning, around 7:30, when women were supposed to be in school, the girls, but they were all there with children on their back, doing all those domestic chores. And I had all this, written materials on the don'ts that you should not do, and most of them were being violated at that point. So it really took me aback, and I had to, try and talk to them, and we managed to get some of them to actually come into the screening that we were offering for cervical cancer, because we wanted to, integrate cervical cancer and FGS in the same. So they actually came, and we got a few that had FGS, and we treated them. Now, one of the success that I can say that we ended up having was we had a 5-day training on the FGS for the healthcare workers, who were around 40. And through that, of course, we diagnosed the cases of FGS and gave the treatment. And we managed to also put up a reporting system. And we are clearly working on the referral system as at now. And also currently, we've also managed to even go ahead to other counties. Currently, we're actually we've just finished our advocacy in the coastal region. We intend to train around 70 healthcare practitioners next week, starting from the 27th of July. So, but one thing that really sticks out, and that's why I say it's really more of a success story, a partial success story, is that it is very evident and it's clear that we need to integrate FGS in various sectors. And this includes the WASH programs, sexual reproductive health, HIV/AIDS, education mainly, gender mainstreaming. I heard that this is a recurrent theme, especially even in the vaccination training that we've just had. The gender barriers are a lot, and we need to really really analyze these gender issues so that if we intend to have the impact that we want, we really need to get on accessing the gender barriers and actually empower women to get the treatment and actually the service that they deserve. So that's basically my story.
Thank you very much, Victoria. Are we ready to watch our guides on the side?
Yes, indeed. I think we may need a few seconds to breathe and reflect as our guides on the side just heard several very compelling stories from Dr. Rabiu Ibrahim, Dr. Mary Ashinio, and Dr. Victoria Gamba. So we're going to start with Julie Jacobson, our friend and partner from Bridges to Development. Then we'll hear from Joseph Opare and Alison Krentel, also friends and partners. They'll briefly introduce themselves. Please focus on your response, your comments, your insights in response to the stories you just heard. And I see Julie has just turned on her webcam. Let me see if we can bring her up on screen as well. That would be great. All right, Julie, the floor is yours. Wonderful that you were able to join us for this session. In a way, I know you couldn't have missed it, but still, you just heard several remarkable stories, each of them distinct, each of them different. What's on your mind as someone who's spent decades, if I can say it that way, committed to tackling FGS?
Hugely inspiring to see what the scholars have done, and just the power of personal motivation to solving this problem. For those of you less familiar with FGS, it's a parasitic infection. Contact with contaminated water, just the parasite penetrates the skin, gets into the body, and lives in the venous plexus of the pelvis, and so affects the bladder and all of the genital tract. And it's just not taught about in medical school, and people don't even know that they're being infected. So what I love about all of these stories is that they tackle each of the different levels of the problem. So with the first one we heard about, it's a lack of understanding and knowledge, and so empowering people with the knowledge that this exists, that it happens. Then in Nigeria, they've created this amazing network of people who are taking on this challenge and working across the country, working with the program, and it is unbelievable the response to this, and it's super inspiring. The second example from Mary of looking at the transmission, until we stop the parasite from continuously reinfecting people, they continue to be at risk. You have to take on that challenge as well, and so that prevention piece and looking up to where does the problem come from, how can we take care of that? And then the third one, if really reaching patients, how do we reach those patients and make sure that they no longer suffer? They're most frequently thought to be sexually transmitted infections, so women have stigma because of this. This is a very much a gender-based issue where people don't talk about this because it affects women's genital parts, which just don't ever get looked at or talked about openly. And so I'm just inspired by the motivation, the creativity, and the holistic approach demonstrated by the scholars. So thank you so much for yourselves being yourselves. That's it. Thank you.
Thank you very much indeed, Julie. Let's now go to Alison Krentel or Joseph Opare first, I believe, and then Alison from Bruyère. Joseph, what's on your mind as you listen to these stories? You're also very committed and dedicated to tackling neglected tropical diseases, FGS in particular. What's on your mind today?
Yeah, so many, and I'm excited to be part of this program. It appears our system in Ghana, right? We got used to female genital schistosomiasis.
Sorry, Joseph, I believe you haven't. You need to introduce yourself first. Tell us who you are, what you do in the Ghana Health Service.
Right. I'm Dr. Joseph Opare. I am the Deputy Program Manager for the Ghana Neglected Tropical Diseases Program, right? So, as I was saying, Ghana, hitherto, these activities were not so privy to female genital schistosomiasis until some few years ago, when through WHO-SN, that is expanded program on elimination of neglected tropical diseases, supported us with some funding to set up activities and also work within the premise of female genital schistosomiasis. So ever since, a committee has been formed at the national level, and membership of the committee forming the National Female Genital Schistosomiasis National Committee includes Public Health Division, right, where we have the Neglected Tropical Diseases Control Program sit. We have members from the Clinical Care Division, Family Health Division, and also Ministry of Education. And our mandate is to push the agenda of the FAST package, which is the FGS Accelerated Scale Together package, into the Ghana Health Service. And this package includes...
Joseph, I believe you've moved away from your microphone, or you've got a finger or a hand. Yeah, that's much better. Please continue.
Okay. So this FAST package includes diagnosis, treatment, training of medical personnel, awareness creation, and prevention of new cases within the Ghana Health Services. So ever since we started doing so many activities on that, right? We're also part of the virtual training that did occur somewhere last year. And as of now, we have the committee formed. We meet twice in a year. And also we have our activities. We have our program of work for this year. And we've done orientation at the regional levels. And for this year, our focus will be on the training of the district health teams. Whatever activity we do at the national level on the NTDP program, we make sure that we include issues on female genital schistosomiasis. As I speak now, next week, we are going to the central part of Ghana, which is Kumasi, one of the biggest cities. There's going to be a training on trypanosomiasis, and we have been invited to give a presentation on female genital schistosomiasis. So it's a crucial issue, and I'm so glad that Dr. Shinyo is on this program, and she's at the clinical side, the clinical care division, and together we are working in such a way that we mainstream issues of female genital schistosomiasis in the Ghana Health Services. Over. Thank you.
Thank you very much indeed, Joseph Opare. Over now to Alison Krentel from Bruyère, a key partner in the FAST package and a great friend and partner to the Geneva Learning Foundation as well. Welcome, Alison. What are your thoughts, having listened to our three speakers?
Great. Thank you so much, Rita, and nice to see some familiar names and faces on the call today. My name is Alison Krentel. I'm at the Bruyère Research Institute in the University of Ottawa here in Canada, and part of the FAST package that you've heard a little bit about. Yeah, just a few reflections. I would echo both Julie and Dr. Opare in just mentioning how inspiring it is to hear all of the three stories that we heard about today. And I particularly was just really intrigued by the integration that was mentioned across the three speakers and integration of FGS into existing systems. And we really know that this is the way we're going to make success. We're going to make progress and have success with addressing FGS. And so I just was I really enjoyed hearing the creative thinking and the personal motivation and just the places where you've been able to leverage existing opportunities, add FGS to the agenda. And I think that's those are such important stories to share. And I would just echo the importance of forums like this, and thank you to the Geneva Learning Foundation for continuing on with us on this. And to see this cross-sharing across different partners, different countries, different kinds of individuals, from doctors to government health workers to nurses to all different levels, information officers, and just having that multidisciplinary approach helps us to be more holistic in addressing FGS. And I guess my last comment is just there are resources available, and I saw that the link for the Global Schistosomiasis Alliance is posted a link there. The FGS Society has been posted in Nigeria, and the FAST package. And so I would welcome those of you who are new to this area or who are involved in this area also to check out those different resources. And also let us know if there are things that we can add, certainly from the FAST package, to highlight other resources that may be available and to share with the community. So thanks very much.
Thank you very much, Alison Krentel from Bruyère. All right. Back to our mistress of ceremonies. For our next speaker to share experience, what have you done since completing the first phase of the Impact Accelerator for female genital schistosomiasis? Charlotte, who shall we hear from next?
Next guest is already unmuted. Whether it is Professor Chinyelu Ekunife. I think, Professor, you're going to just succinctly say a few of the things, because I know you have probably done so much since our last Impact Accelerator. But if you can choose to share maybe your success story with us, we'll be very delighted to hear from you, keeping in mind that there are many other people that need to share their stories as well. Over to you. Are you able to introduce yourself? I see your mic is unmuted.
All right. Here we go. Chinyelu Ekunife. Yes, well, warm welcome to you. Is your story a success story?
Okay. Good afternoon, Reda. Good afternoon, Charlotte, and everyone here present. My name is Chinyelu Ekunife from Nigeria. I am a teacher in the university, a public health parasitologist, and my research interest area has been urinary cancer. I've done lots of research in the area, though throughout the time I've been researching, I've never heard of FGS. I only hear of urogenital schistosomiasis and so on, until after the FGS workshop and the Impact Accelerator which exposed necessary information on FGS. After that, I decided to at least work on my students first. What I did was to meet my head of department to improve the curriculum parasitology. So what I did was this course called Advanced Hermetology. I made sure I introduced the topic female genital schistosomiasis. Also, for my postgraduate students, undercurrent trends in parasitology, I also introduced that topic, female genital schistosomiasis, and I handled that course personally. Then, as a result, I also developed a sort of manual, which I will use to organize workshops.
I think, Charlotte, we just lost our speaker.
Yes.
She just dropped off. Okay, that's unfortunate. We'll pick up where she left off. Charlotte, I believe you probably already have a next speaker lined up and almost ready to go.
Definitely, Reda. I'd like to invite Dr. Soneye Isliamat, who will be able to Soneye, are you able to unmute yourself to share your experience with us? That is almost in the same line with what Chinyelu was sharing. I'm asking you to unmute.
Yes, okay. Here we go.
Hello, can you hear me?
Yes, we can hear you now, loud and clear. So, Soneye Islamiat, a warm welcome to you. Is it a success story, a lesson learned, or a challenge that you'd like to share?
Okay, mine will be 3 in 1.
All right.
Yes.
Do introduce yourself first.
At the same time, I've learned a lot of things, and it's opening up room for improvement via challenges. Okay, so good afternoon, everyone. I'm Shona Islamiat. I'm a public health physician from Nigeria, Ogun State to be precise. I am the State Neglected Tropical Disease Coordinator, and I was opportuned to be part of the training for FGS scholars last year. So after this training, we were mandated to have some action plans that we worked on. And along the line, I just realized that at the level of my program, we've just been like, what we've been doing has been a tip of the iceberg. Because basically the administration of medicines we do target school children. So at the end of the day, we've saw that we have been able to neglect people in the community. Most people in the community don't understand what schistosomiasis is. Talk less of female genital schistosomiasis. So immediately after the first package and the accelerator training that we had, I went back to my team. I sensitized them first on female genital schistosomiasis. I also joined the FGS network under the leadership of Dr. Rabiu and other colleagues. So I joined my team members, and we made it a point of duty that every mass administration of medicines that we do in the state, and every sensitization activities that we do, talking about NTDs, we make sure we incorporate FGS into that activity. So one of such activity was we were called upon to a particular community in one of our local governments, in which about, let's say, more than 60% of the people in the community are urinating blood, and they see it as a normal thing. It was an accidental finding, and so we rise up to the occasion, and we went to that community. We sensitized them. We talked about water, sanitation, and hygiene to them. And I just realized that there is a whole lot of work to be done with respect to sensitizing the populace. As I speak to you now, I have about 2 or 3 other complaints from some other communities, and I will want to plead, because as it is now, I'm going back to our national office to intimate to them that as a matter of urgency, we need to include FGS case finding into the national protocol, into the national strategy for NTDs. Because if we don't do that, there's no way we can stop the menace of FGS. So we are continuing with sensitization activities. At the same time, we are trying to create awareness across board. So I really hope that we get more people into the NTD, into the FGS society. I'm happy that a lot of people are identifying themselves with us. I hope that we could get more partner support for the society, and I hope that the society can also work more with the NTD National Office so that we can lay out a strategic plan on how to curb the menace of FGS in our communities. Thank you.
Thank you very much indeed, Soneye Islamiyat. All right, Charlotte, let's hear one more speaker, and then we'll go to our guides on this side. There's also a question from Martina Ezama, who says, Martina's concern is, since this condition is waterborne disease, do the communities have other alternative water supply? Drugs alone cannot eliminate the disease. I'm sure that our guides on the side, as well as FGS scholars in the room, would love to answer that one. But first, let's hear one more speaker.
Yeah, Reda, I saw Chinelu is back in the room, so we could listen to the later part of her story before we will turn towards Anthony Bete from Liberia afterwards. So Chinelu, and you promise that your connectivity is much better now.
Yes. As I was saying, right now, 2 of my postgraduate students are in the field working on urinary on FGS. And I'm also in the process of organizing a workshop for some lecturers that are interested. Though ASU is on strike, so that one has been put on hold. But then, for Female Genital Schistosomiasis Society of Nigeria, after the formation, which Rabiu gave an insight into, I was made the coordinator of my state, Anambra State Chapter. And we had our very first meeting with 5 pioneer interested members on 11th of May 2002. Where we also had to bring in the state coordinator who sat with us to decide on the way forward. We also talked with the NTD person in the federal character to Dr. Benebe. So right now, we have about 7 members and other students that are in the field. So I will have our plan, our activities to map schistosomiasis in the state again. Also, we resolve to involve the nurses who are always in the health centers that are familiar with these community people that are suffering from FGS. So though we have challenges, which I spoke with Rabiu on somehow fund, because we have to bring in those working in the different local government area. It has been exciting, and most people are now becoming aware of FGS. Thank you. Over.
All right, Charlotte, let's take maybe one more speaker. And thank you, Chinyole Ekwunife. Let's take one more speaker before we go back to the guides on the side. I urge you, because there's so many speakers who have yet to speak in the room, please be concise, get to the point, and focus on sharing a specific story, a success story, a lesson learned, or a challenge. We can dispense with general considerations and really get to what's the situation, what happened, why does it matter, what did you actually do? Over to you, Charlotte.
Already, I'm inviting Anthony Bette. Anthony, are you able to unmute yourself from Liberia? Okay,
yes.
Over to you.
Thank you very much. My name is Anthony Kekula Betty. I work with the Ministry of Health. I'm the National Schistosomiasis Coordinator, and I'm an epidemiologist by profession. So, concerning FGS in Liberia, as the Schistosomiasis Coordinator, we have been treating school-age children and adults in highly endemic area until 2019, when the calling time for neglected tropical diseases count down, along with the Ministry of Health and the University of Liberia Pacific Institute for Research and Evaluation developed a proposal to do a research in two of the endemic districts in Bon, Nima, and Nima County. So, during that research, we developed a training manual for the health worker for the detections and identification of female genital schistosomiasis in Liberia, and we were the first time. And we also trained health worker in the district in 36 health facilities, and then also 120 community worker. So the story is that in one of the clinics, there was a lady who was just being treated for sexually transmitted infections, and then she had almost all the signs and symptoms of FGS, discharges, sometimes bleeding. And as a result of that, she lost her relationship with her husband, and then she had a first child almost 10 years ago, and then she could not conceive. So after she was diagnosed of FGS and treated, her condition began to improve, and then she came back to the clinic to inform the health worker that, you know, the medicine she took is actually helping her. And then later, she conceived after getting another man. So that's a success story. So that her condition went away, and now she got pregnant, and she lived a very happy life. But after the research, there were a lot of things that we did. We did a dissemination to the community, and also the NTD program in Liberia being an integrated program. So FGS was also integrated into the health information system of the Ministry of Health for those two districts. So they report on a monthly basis on the number of FGS cases actually they are getting. So there are also collaborations of the health system, strengthening integration with other health programs within the Ministry of Health, more especially the reproductive health and family health division. So FGS is actually becoming visible. So we also have some referral system put in place from the Bureau health facility to the hospital. So we trained 2 doctors from the hospital to also handle those cases that have been referred from the hospital. So exactly what we are doing in Liberia. Thank you.
Great, thank you very much indeed. We're now going to turn to our guides on the side. Let's go in reverse order. So we'll start with Allison, then Joseph, then Julie. Because the clock is running and there's still a number of speakers who really want to share their experience, I'm going to ask our guides to be concise as well and to get to the point. Thank you. Drawing on their considerable experience and expertise to help this group think about the stories we heard and what they mean. Allison, we'll start with you.
Great, thanks, Reda. Just 2 quick points. One, on the WASH. I've put a couple things in the chat, a link to the WHO WASH NTD guide, which provides some information on the integration and importance of WASH when we think about neglected tropical diseases, in particular schistosomiasis, and just recognizing that for so many communities, there are no alternate water sources. And so this is a really important point, and one that we have to bear in mind when we think about FGS prevention. And so that awareness is really important, and also continued WASH, also in terms of latrine usage. And the second is just to highlight Dr. Bette's point about stigma, and just really the importance of the mental health and stigma that is associated with FGS, and that we really need to, when we think about a holistic approach, it's so important to consider that story that he just brought into mind. And I'm sure many of you on the call can relate to the experiences that he shared. But considering the mental health really needs to be an important part of our approach to FGS. Thank you.
Thank you very much, Alison. Over to you, Joseph Opare, from the Ghana Health Service perspective, as you are the Deputy Director of neglected tropical diseases.
All right. Thank you very much. Thank you very much. It appears a lot has been done. And I just wanted to add that Ghana too has received some training manuals, teacher training manuals. And in the development of the manual, with the female genital schistosomiasis National Committee put in a lot of inputs. And we are so glad that now this booklet is being shared all over, and it has been very useful. Fortunately, I'm with one of the committee members, that is Mrs. Rebecca Bante, right? And I believe she also has something small she may like to say about female genital schistosomiasis and what she's seen so far, the committee doing. Becky.
Thank you. And now we will go to Julie Jacobson.
No, Becky is coming on board to share just a word.
I see. Sorry. Sorry, Joseph. Please proceed.
Okay. Becky.
Thank you very much, Dr. Opare, my boss, for the opportunity. From where I am coming from, I would want to share a success story as to how I got to know or get to hear of female genital schistosomiasis, and my appointment or nomination to serve on the FGS committee, what has been done so far and what we intend doing. Greetings from Ghana once again. The committee at the national level, apart from the sensitization at the national level, the regional level, there had been so much, comprehensive and holistic approach. We are not only sensitizing or training the health workers, but also our friends in the education sector. So there is this collaboration between the health sector and then those in academia, where we also benefited from a training from Dr. Jacobson and her team, Dr. Margaret Japan from University of Allied Health, Allied Sciences. Apart from the training of the expert committee, at the district level, my background, I happen to be a trainer in cervical cancer screening. So in 2015, I was trained in the basic training, that is VIA. I was given the training by Female Cancer Foundation from the Netherlands. And then later on, I trained in how to do colposcopy. And I had been rendering the services ever since. Until 2020, when my region was fortunate to be trained or to be exposed to female genital schistosomiasis. Though I worked in a schisto-endemic area, I never had any information about female genital schistosomiasis. So during the training, some pictures were presented. It was there that it clicked to me that, wow, we missed so many opportunities during the screening for cervical cancer. You know, the concentration was on the acetowhitening around the transformation zone when it comes to cervical cancer screening. So we missed these opportunities. And what even paid me so much was the fact that most of those women, after hearing the announcement of the screening, came with the problems such as STIs, recurrent STIs, or infertility. So now, having the knowledge in FGS and then the possible complications, it came clear that we missed on these people, probably because their problems might have been FGS and not STIs, because they kept on, the disease conditions kept on recurring and recurring and recurring. So getting the opportunity, as a district director, we decided to create much more awareness, train as many people, as many health workers as we can, and screen as many people as we can, and also to advocate for the inclusion of praziquantel being the magic drug on the Ghana National Health Insurance Scheme, and also to develop a vibrant data validation at the district level, so that whatever, anytime we validate our data and we see much of STIs, then we have to be thinking FGS as well. So far, so much has been done. Education department, health department, and TD program is doing marvelously well, and all hands are on deck, and gradually there will be a success story for the whole world. Thank you very much. Over.
Thank you very much indeed. Back to you, Joseph, or over to Julie.
Thanks. And thanks, Joseph, for making sure that story got told as well, because I think, what's really inspiring to me is I love how Anthony brought in the very personal experience of what an individual has and how who has FGS and how that affected her life, losing her first marriage, being misdiagnosed repeatedly with sexually transmitted infections, the very personal suffering that comes from this and how important it is to solve it. And then I really like hearing the last story, which is about from a practitioner's piece, where you've seen these lesions for years but didn't know what they were, and they just were ignored within the system, and how the awareness of that can totally change the lives of the women and girls that are suffering from this and at risk. I really appreciate also the persistence of Chenyu. I don't know how to say your name, apologies, but of saying, like you lost the line, but getting back on the line, because that's the kind of persistence that it's going to take for us to be able to overcome FGS, and getting training into the systems for nurses, doctors, and community health workers, but also doing the training that reaches people who are practitioners now so that they can do something within their practices now, which we've heard about also from across these different speakers. So I really appreciate all of these pieces. And the risk of reinfection, I wanted to just say one more thing about that, is that, once you've treated somebody, that they're living at risk. And as Allison pointed out, the water sources, contact with water is within the daily life of people around the world. So, whether it's getting water for the family, washing the clothes, washing the children, washing the car, bathing, so the risk of re-exposure is always there. So once you know that it's within a community, we have to be persistent and continue to treat recurringly for the risk of that happening again. So thank you to all of such inspiring work, and thank you to all of the FGS scholars for the time and energy and passion you're putting into this for the women and girls that are suffering from FGS.
Thank you very much indeed to Julie Jacobson, Alison Krentel, and Joseph Apari, our guides on the side for today's session. I'm sharing on screen from the plenary of Teach to Reach messages from Fanny Ogu, who says, Charlotte, thanks for rightly capturing FGS as the most neglected female disease. And Joy Chikwendu says, amazing session on FGS. I have learned a lot. Thank you, Joy, for listening, and hope you will look at and consider the resources we're going to be sharing out as we go. Wonderful. Thank you all. Thanks to the FGS scholars. Very impressive what you have done, what you are doing, what you continue to do across a number of countries that actually were not included in the FAST package. But that thanks to the power of digital technologies and digital networks, we're able to include working with the FAST package and our partners. Thank you once again. This also closes Teach to Reach. The networking remains open for another 2.5 hours, I believe. But with Charlotte, I want to thank Charlotte, and I want to thank the rest of the Geneva Learning Foundation team for another amazing Teach to Reach. This is the 6th quarterly edition. The next one will be announced soon for the early fall. And I just want to ask Charlotte to share her last words as we close this Teach to Reach.
Thank you so much, Reda. I'm going to attempt something, see if it works, like turning on my video for the first time today. I think I can risk it now because we are almost at the end of Teach to Reach Connect 6. But I would like to thank everyone for joining us today, and most especially I want to congratulate those who joined for the first time and were able to stick till the end. I'd like to thank all those who took the time to share their experiences, their stories of what they are doing on the field, from immunization to FGS to gender barriers in immunization. Thank you all so much. I'd like to thank our guides on the side who were there to listen keenly, attentively, and to share their very useful insight and expertise that will help our members.
All right, I think Charlotte, your connectivity is breaking, and that is how it goes.
It's always a great pleasure to accompany you.
All right, wonderful. Thank you, Charlotte. Thank you all for this amazing edition of Teach to Reach. And we'll see you soon. There will be a number of key documents, resources will be shared out over the next 4 weeks, including, I'm just going to give you an overview from each of the plenaries. So from the plenary on COVID-19 vaccine demands, we'll be sharing out a report analyzing 734 case studies developed by local health professionals on how they successfully tackled vaccine hesitancy where they work. This will be ahead of the UNICEF Vaccine Demand Global Event, which all Teach to Reach participants who share a story in relation to COVID-19 vaccine demand will receive an invitation. That is happening on the 22nd and 23rd of June. And of course, for the session of the Women Who Deliver Vaccines, the collective will be opening up to new members. So you'll be receiving an invitation. Let me see if I can find that slide, which I actually really appreciate. So let me see, where is the Women Who Deliver? Yes, here we go. So that is for Women Who Deliver Vaccines. We'll be sharing out, again, the invitation will come to you from the Geneva Learning Foundation, but actually from the collective of women who will be inviting their sisters to join this collective. And for FGS, we hope that this experience sharing, will be discussing it with partners and FGS scholars. If you'd like to see more events like this, let us know. It is important. We'll be asking you for your feedback very soon in your inbox. You'll have 2 weeks to give feedback, and that is also people who share stories, who tell us what they appreciated, what insights, what they learned through Teach to Reach. Will also be receiving an official letter from the Geneva Learning Foundation confirming their participation and contribution to Teach to Reach. Once again, thank you and take care. We absolutely need to commend Omolara Adeyemi, who has attended all 6 Teach to Reach events. Congratulations. I know there's a group, we know who you are, who have done that. I think we should give you a special letter of commendation. Take care.